Start, Uma, Dr. Uma.
Shall we start? Okay.
Yes.
Okay, good evening, everybody, and welcome to this third day of the certificate course on mental health of women across their reproductive cycle. Before we go on to the overview of the day's course, it's my absolute pleasure to invite Dr. Sarita Bhalerao to say a few words. Sarita is the Vice President-elect for ICOG, has just completed her term as Secretary, and more importantly for me, a good friend. So over to you, Sarita.
Thank you, Dr. Uma. And really, I'd like to congratulate the whole team for such a wonderful course. I've been listening to it. And I think it's going to go a long way in sensitizing our members towards this very difficult and important topic of mental health. We do emphasize a lot on physical health of the pregnant woman and physical health of our women in menopause, but what we do tend to neglect, whatever it is, because we are busy, because of lack of time, because of is the mental health. So I think this course will go a long way. My congratulations to Dr. Sheila Mane madam for taking this initiative, and to Dr. Pratik Tambe for all his very sincere work in organizing this, and of course to Dr. Uma. I know how passionate she is about mental health, and I'm happy that we can collaborate with ICOG and RCOG IRC on this topic. I think our co-conveners, Dr. Anita Rajoria, Dr. Shashilata, and Dr. Lata have done a great job. And our coordinators, Dr. Shaijas, Dr. Meeta, Dr. Kiran, and Dr. Deepa, have also done a lot of hard work in maintaining the timing and keeping everything going. And thank you so much to the faculty for taking their time off on a working day evening for for their efforts in this course. So with that, I wish you all the very best, and I look forward to this last and final day. Thank you.
Thank you very much, Sarita. And now it's my pleasure to invite Dr. Tambe to say a few words. I think he's been here every day, and as Secretary of ICOG, thank you very much for the opportunity, and over to you, sir.
Thank you very much, Dr. Umaram and the entire RCOG team for collaborating with the ICOG team led by Dr. Sheila Mani Madam and myself. Thank you very much to all the course coordinators, conveners, all of the faculty who put in a lot of effort over the 3 days to convey some very important concepts to all of us. Just as I said yesterday, it's not part of our classical undergraduate or postgraduate teaching to talk about mental health. And mental health is a big stigma even today in many parts of our country. I think this course will go a long way towards sensitizing our common OBGYNs in the small towns, villages, and smaller cities to understanding these concepts and hopefully putting them into clinical practice so that we can move forward with the times. Thank you very much, everybody, and let's get on with the academics.
Thank you very much. So today's course, in today's sessions, we will cover fairly important topics around preconceptional care of women who already are on medication or who are known to have mental health problems. And then we'll move on to discussion and around management of depression and anxiety in pregnancy. And then move on to the third topic, which is not that common, but can be a very challenging when it happens, is managing psychiatric emergencies during pregnancy and postpartum period. How do we respond? What do we do when it becomes very important that systems are in place to manage it? And the last topic for the day is something that we all need to pay attention to, which is our own self-care. We are already seeing a lot of burnout. We are seeing, people, obstetricians who are much younger than us who are talking about burnout, many not wanting to do obstetrics at all. So I think as a very high stress specialty, we'll have a short discussion around how we need to take care of ourselves. So that's going to be the flow of topics. And so I now request the chairpersons of the day to take this forward?
Coordinators.
Yeah,
The coordinators.
thank you, ma'am. I'll take the session forward with your permission and Dr. Sheila ma'am's permission.
Please,
Of
please.
course,
So,
Anita.
yeah. So, for welcoming chairpersons for first session on preconception counseling in mental health disorders. So, I invite my respected chairperson. First is Dr. Surekha Tade. She's a well-known figure in FOGSI circles. She's the professor and IVF in charge. Punjab Rao Deshmukh Memorial Medical College, Amravati at present. So many achievements to her credit. She has been chairperson of Clinical Research Committee, and she has motivated all of us to contribute towards some research work also. Thank you, dear Surekha, for that. Welcome to our session. The next chairperson is Dr. Aruna Suman. She's currently the chairperson, holding chairperson, organizing secretary to various conferences. And she's currently chairing the exchange committee, academic exchange committee, FOGSI 26-28. She has contributed immensely for FOGSI conferences and other things. She's an avid academician and teacher also. And the third chairperson is Dr. Nivedita, another professor. Welcome, ma'am. Welcome to our session. She is the professor, Department of OBGYN at Puducherry, and she has been coordinator for FOGSI Clinical Research. So much.
Thank you,
so
ma'am,
much,
for the
ma'am.
opportunity and having me here.
We are looking forward to hear from you as an expert for this session. And the speakers for the first session for preconceptional counseling is none other than our respected Uma ma'am once again, and Dr. Ashlesha Bagaria. We have been listening to her. She has been introduced multiple times. So over to you, ma'am. We are eager to listen to you.
Thank you very much, Dr. Anita. And at the outset, let me thank Dr. Sheila Mane and Dr. Pratik and all the executive members of ICOG for inviting me to chair this session. And as we all know, preconceptional counseling has been the highlight of FOGSI's year last year, and definitely mental health, perinatal mental health is very, very important. We many a time talk of other disorders, physical conditions, but mental health takes the backseat. But definitely, if a mother is strong mentally, she can go through her pregnancy and have a successful outcome. So we would like to hear from Dr. Ashlesha and Dr. Uma Ram for preconceptional counseling for common as well as severe mental health disorder. Over to you, ma'am.
Okay.
Thank you very much. Definitely something that's very close to my heart. Can everyone see the slides?
Yes, ma'am, please go ahead.
Okay. So what we wanted to highlight today's discussion was when you see someone who may have a known history of mental illness or undisclosed history of mental illness, may be on medication, may not be on medication, but what are the things to keep in mind, either when they're already pregnant or planning pregnancy. And we are going to do this by highlighting through two case scenarios. I'll invite Dr. Ruma to go through the first case for us.
Yeah, thank you, Ashlesha. So this was a 29-year-old lady who had been married for about 2.5 years. She had had a termination of medical termination of pregnancy about a year ago, because at that time she felt she was not ready for a pregnancy. And she has specifically come in to consult because she was planning a pregnancy, and she had been on sertraline 100 milligrams a day and clonazepam 0.5 milligram twice a day for anxiety since the last 3 years. And she was on these medications when she had the termination as well. She had read and she had been told by both her psychiatrist and another gynecologist that ideally she should not be on clonazepam when she is planning pregnancy. So she had tried to reduce clonazepam in the past, but that always resulted in an exacerbation of symptoms. And so she was concerned about how she should go ahead and whether it was safe for her to plan pregnancy. So this was somebody who had insight into her condition, who was well controlled on 2 medications, but was aware that ideally she should not be, I mean, she should preferably not be on one of those 2 medications, and was asking for advice on how she should go about it. So when I spoke to her, I first of all was, tried to evaluate that that her anxiety was under control and she was coping well, which she said she was. And so I reassured her that sertraline is okay to continue in pregnancy, that it may not be possible to go off all medications, though in the ideal world that would be the scenario that everyone hopes for, but it may not be practicable. And if she went off everything and actually the anxiety worsened, then that would be worse for her pregnancy than continuing on safe medication. And suggested that she goes back to the psychiatrist to see whether the clonazepam could be modified or the dosing could be changed. And she had also just shifted into this city, so she needed to find a psychiatrist as well, which was also a point of concern for her. And of course, in today's world, remote consultation is still possible, but I think with psychiatry, Ashlisha, women are far more comfortable sticking to this person they have been treated with than move. So these were all the situations. So this was my advice to her. So I just want you to tell me if you would, if that was fine, if you would do anything differently. And then we spoke a little bit also about pregnancy itself, but we can come to that later.
Yeah. So what you did quite well there is that you determined whether her symptoms were well controlled, and that is the primary goal, really. When someone is already on medication, has perhaps got a diagnosis of anxiety, common mental disorder, then the first thing we want to know is that is the condition well managed? Um, and also whether she needs to be on medication or not is something perhaps her psychiatrist should take a call. And invariably, what we need to do is err on the side of making sure she's symptom free during pregnancy rather than medication free, because we know the side effects of the symptoms of illness are far worse and almost absolute compared to the relative lower percentage side effects of the medication, especially something like sertraline. And of course, something like clozapine we know is not safe during pregnancy. So she was given the right advice to come off it. And that is again something very hard to come off on your own. And the chance of her having withdrawals from clonazepam, which can mimic the side effects of anxiety or mimic the relapse of anxiety, it's best that it's done under supervision. And so your advice was absolutely spot on. What we really want to look for when we are thinking about suggesting or planning pregnancy for someone who has anxiety or depression, who's on a medication that is relatively safe. One is the condition in control? And the second step, of course, are the medications appropriate? And for both of this, it's good to make sure that they are consulting a psychiatrist that they feel comfortable with. And here she was willing to go and see someone new, but I felt like you said, she probably felt better to see her psychiatrist online. What is more important though is this psychiatrist communicating with you, because you want an open communication with the psychiatrist throughout the pregnancy, not someone who is giving advice without collaborating with you. So that is another factor to consider as well, to aim and encourage for collaborative care for someone like this. You don't want the psychiatrist to just be giving medication advice without working with you. So encourage that. Definitely not stop any medication on your own, which you did. Again, you didn't do that. Or don't try to start any medication on your own, because we don't know. Sometimes a plain anxiety could actually have other factors underneath. This could be something like OCD, which we know can get really exacerbated in the postnatal period. So it's best to work collaboratively. Now, with someone like her, especially when they enter, depending on what kind of anxiety they have, when they enter the phase of pregnancy and postpartum, it is one of those phases in a woman's life where it is the most concentrated period where maximum number of decisions they are exposed to in a very short span of time, and they also have to face a lot of uncertainty in a very short span of time. We by and large we know that majority of the cases it goes in a certain way, but how they are going to feel, which symptoms are they going to experience, whether it's going to be backache or whether it's going to be a pain in the ankles. So each pregnancy brings with it an unpredictability, and for someone with anxiety that can be quite difficult. So symptom control is very important. So keeping that in mind, and also another thing that we have to keep in mind is during pregnancy, the volume changes can happen. So dose adjustment needs to be made by regular monitoring with a psychiatrist because of volume changes. Some people don't need a dose adjustment at all. Some people may need a dose adjustment. So these are the concerns you want to watch out for during pregnancy. Watch out for mood changes during pregnancy that are similar to theirs rather than just what you might see in normal pregnancy. And if
So,
a medication is prescribed in pregnancy, like sertraline, for example, then we know that sertraline passes even less through the breast milk barrier than placental. So it's completely safe to continue in breastfeeding as well. And counseling them for that is quite important. Another
yeah, you
factor that
often
I
have
think is important that you would want as obstetrician is say smooth management of labor as well for her. You don't want her to be anxious and uncomfortable and struggling during that time.
yeah. Yeah, very true. So I think conversations around the changes in pregnancy, the fact that there will be points in time where she's more prone to have symptoms, and be aware that to inform us when those changes are happening, I think is something we should also talk to them about, as you mentioned. I had a so the we've said now we need to wait till all this settles, and if you're going to change medication, that's not the right time for you to get pregnant. So we should spend a little time advising contraception, and that's where sometimes we get into a little bit of a we get a little confused because in her case, at least, her cycles are regular. She has used some contraceptive for the last year, probably barrier, which has worked. So it's okay. But there are some where they are not comfortable with barrier use or cycles are irregular. So, in terms of a hormonal pill, which probably will be the safest contraceptive that we would offer in most situations, in someone who's on medication, I know we touched upon this in the first day, but just a quick recap that in terms of giving her contraceptive advice, because the last thing you want is for her to conceive when she is transiting or changing medication, isn't it?
Absolutely. Yeah, and this is something that is so crucial. I mean, we did a little study in Niman some time back where we were asking how did mothers who were on psychotropic medication make decisions around pregnancy. And they were in in the perinatal clinic in Nimhans, one of the premier institutions. There are psychiatrists, there are speech pathologists, there's psychologists, social worker. They've seen all these clinicians, and if they're little symptomatic, they've been told wait for some time. So my job as a researcher was to ask them, okay, what advice did you get today? And they said, we've been told to wait. So I would ask, are you okay to wait? They said, yeah, we'll wait. We've been told to wait for 3 months. Okay. Are you sexually active? Yes. Are you using contraception? No. So I was baffled. Like, what do you mean by wait? It's almost like waiting means we're not going to actively think of having a baby or something. So it was very bizarre unless they were directly told to use
Yeah.
a contraception. So I think this is a very important point you brought up. And if their symptoms are adequately controlled, I think it's all right to put them on the pill like we mentioned before, but also to counsel them that it's best for you to manage this with as much control as you can possibly have. And already when you're managing medications, there's a lot of unpredictability to come. If you have an unpredictable pregnancy, that's going to throw everything off. So planning this and doing it in a more structured way is going to be definitely more beneficial to you. So sometimes they may say yes, yes, and they may not really follow that through, because the underlying fear in most people is, what if we don't conceive? What
Yeah.
if we delay it by using contraception now and then it's too late? No matter how much you counsel them, they tend to think like that. So it's best to sort of suggest that this medication you're taking, clonazepam, is not going to be safe. You're going to be in a bigger dilemma if you get pregnant while you're on this. So, be a little bit more serious about contraception, and it's all right to do whatever is most effective.
Okay. All right. So we'll move on to a slightly different scenario. So this was a 28-year-old. Her BMI was 32. She had irregular cycles. She was diagnosed to have schizophrenia at the age of 22. And for the last 3 years, she had been stable on a regime on medication, which is quetiapine at 300 milligram and risperidone. And now she was seeking treatment to regularize her cycles, and because she was very keen that she should plan a pregnancy. Now, what was interesting in this conversation, and this happens often when you have women who have schizophrenia or significant mental health disorders, is there. Usually it's the mother, sometimes it's the spouse who leads the conversation and is answering the questions that you're actually directing to the patient. So so sometimes it is important for us to judge whether this woman has the ability to, what is her comprehension? Is she understanding what we're saying? Is the consent and the desire to have a child hers, or is it the families? Because this has also happened. So I think there is an ethical issue here on which I would like a little bit of your input, because as an obstetrician, you're caught not quite, you don't want to offend the mother by saying something, but at the same time, we need to do right by the woman. So something on that before we get into the nitty-gritty of the medication. Obviously this again has to be a joint effort, a collaborative treatment where the psychiatrists and the obstetricians are completely in sync. Being aware, I think most of us would be aware that risperidone in itself could be a reason for the cycle irregularity,
Exactly.
because of dopamine and prolactin impact. And ideally, we would take her off that without losing symptom control. And again, all of this is going to take time. So what would your thoughts on how we should approach this, Ashlesh?
Yeah. So again, so many factors to consider here, right? And sometimes in this situation where there is another person sort of leading the show, and if they're stable on medication, we also want to make sure that they have just not been taking the tablets and not been going back for psychiatric review, which is another very common thing that can happen, especially with schizophrenia. The stigma of going back to the psychiatrist, why bother? At least the good thing is that here she's continuing to take the medication. So in making sure that they've had a recent psychiatric review is important. But in this situation, especially because there are two medications involved, what we want to aim for is optimum treatment so that her symptoms are controlled. Again, another condition where if she has psychosis during pregnancy, the negative impact of it, we have lots and lots of evidence now to say that the impact of that on fetal growth, on sensitization to the fetus to future mental illness, on cognitive impairment is significant just with the illness alone. So the exposure to illness is going to be much more harmful than the exposure to medication. Especially quetiapine is generally safe, but what we want to do is not necessarily give her low dose of two medications, is to have reduce it to one medication, but have it as a optimum treatment, because the exposure is not dose dependent, at least not at these doses. So quetiapine becomes harmful, say, if it is above 600 milligrams, and very high doses. So for her, it actually, like what you noticed and pointed out very accurately, is that risperidone possibly is also causing these prolactin changes or impact on menstrual cycle. So there is some scope to review, get her medications reviewed and optimize it to a monotherapy if possible. Sometimes it may not be possible if there one medication is being given for psychosis and the other one is acting as a mood stabilizer. In either case, referring to a psychiatrist and someone who can work collaboratively with you, so you can also make sure that you're both sort of on the same page. um, and someone like her, like you said, mother is making all the decisions, and the initial thing is for us to sort of see, can we talk to her alone to get a sense of, how much does she understand about her illness? Does she understand that if she stops taking medication she might become ill? Another sad thing that I've noticed sometimes is that the reason why people want to become pregnant, one is because somebody else wants a baby, and grandparents and all of that. But the other thing is that if their illness is known, which is quite common by this stage of their life, that if their illness is known, then they may be feeling a stigma, and having a baby is almost like a way of proving that they're fine, is to almost reverse that stigma. So many people say, like, okay, at least they will look at me differently if I have a baby. And while it looks like the wrong reason, it's almost like a little bit of a higher level of thinking that they're recognizing the stigma, they're trying to overcome it, in some way or the other. But that also may mean that it may put a lot of stress and pressure on them to make sure that the pregnancy goes well, to make sure that, more often than not in many families, unfortunately, still to have a male baby. So, this kind of pressure, we have to sort of make sure that at least elicit and see if it is there and counsel the family. The commonest one here, especially if the mother is leading the kind of thing, it might be important also to tell the mother this is a good time to encourage the patient to develop some skills on her own, to try and make some decisions on her own. And of course, if she's unwell, then other people have to come in. But if she's doing well, taking her medication, the more she tries and figures things out on her own will be good for her and good for the baby as well. So a little bit of your role might also be to take her consent. How is she feeling about going ahead with all of this? Because you don't want, again, another situation where during delivery, if she becomes unwell, then you're left with a very difficult situation, the psychotic mother unable to give consent. So the consent and capacity to make a decision is more important. Of course, we don't really do any capacity assessment of ability to parent, because by that, if you start doing that, almost all of us will fail. So what I have found is, with or without schizophrenia, actually mothers with schizophrenia are quite good. If they're stable, they are able to manage their baby. They have a really good way of managing. So having psychosis doesn't preclude them from becoming a parent. And sometimes, especially well-meaning mother might say, I'm going to take care of everything, I'm going to look after the baby, so they may
Yes.
not even give her a chance to look after the baby, and that's really important also to think about in this case.
Yes. So thank you, Ashlisha. I think that covered a lot of issues in this case. And one of the, there is a question I think Sureka has asked is, if she, in the previous scenario, if she did conceive when on clonazepam, should we be considering termination of pregnancy? Generally, I mean, I think as with most medication, we don't routinely advise termination because of clonazepam exposure, but it's a conversation to have with the woman also. And what is the dose that she's on? So what would be your take on it?
Yeah. So it's almost like, if a mother has been exposed to, say, cannabis, opioids, they go ahead and go ahead with the pregnancy in many countries. So the idea is to reduce the exposure as safely as possible. Again, like you said exactly, we're not going to recommend termination. What we would recommend is closer monitoring, check for scans and see if there are anything coming up in the scan. One of the things, difficulty might be the sluggishness and drowsiness that there might be bradycardia. So you might want to just monitor her a little bit closely, see if she can be safely weaned off the clonazepam in a very slow manner over few months if it's possible. But definitely recommending termination might not be the uh, uh, best decision. Again, you have to, again, for all of these situations, every case has to be taken on its own merit, and you may have to weigh the pros and cons. You definitely should not be recommending termination because we don't quite know whether that is something that is going to be an outcome in the baby. So if a scan reveals something that means that the baby, the baby is compromised in some way, then you can have that conversation. But just as a response, I wouldn't say you need to recommend termination. Also, the dose she was on is not a very high dose. So you can sort of say that it's possible for her to have got that exposure and still not have harmed the baby. So the idea is to make sure that she has symptom control and safely wean off the clonazepam.
Thank you, Ashlisha. The other issue is that even though it's pregnancy management, very often there are two questions that come up in the preconception consult. One is around breastfeeding, because a lot of mothers feel that it is terribly important for them to breastfeed, and rightly so. And they are very worried that this medication is going to prevent them from being able to feed. And I once had a lady who told me, I know what these drugs do to my brain, and therefore I don't want them to be impacted on my baby. And so I opt not to feed, even though you are telling me that you can feed. It was a very interesting conversation. Uh, so I think, we have, but in general, most mothers do want to feed. So we are very promotive of breastfeeding. Of course, unless they're on, which is why we don't have them on any of the, we don't use lonazepam or clonazepam at that time because of the impact on the baby also.
Mm.
But this belief of you feed, you take the tablet, you wait for 2 hours, and then you give, that is no longer something that we need to advise women, isn't it? We can,
No.
in general, be reassuring about the safety of medication.
Absolutely. And what I definitely tell them is that if you have been taking the tablet during pregnancy, the placental barrier exposure through the placenta is a lot more than the exposure through breast milk. It's 0.03 or something. And so, what you're actually doing is you're safely weaning the baby off rather than exposing during pregnancy and suddenly not breastfeeding. You're actually exposing to lower dose and then weaning them off naturally over a period of few months, so they're hardly going to get any exposure, and it's a safe way of continuing the medication or exposure for the baby. So it's a little safer to continue breastfeeding and for the baby as well. The other thing is that if they breastfeed, it's actually important to rally around with other people in the family to encourage pumping and feeding the bottle so that other people can also participate in the feeding. And one of the things that often becomes a dilemma is protecting their sleep,
Yeah.
because for many women who have a pre-existing mental illness, lack of sleep can lead to a higher chance of relapse. And if they're breastfeeding, then they definitely will have sleep disturbance. So I know couples who have sort of said, they'll express during the day as much as possible while breastfeeding. And so breast milk is then given in the night by the carer, someone else, while the mother sleeps. So balancing protecting her sleep and encouraging breastfeeding along with getting the dad and other people to do something is very important.
Yeah.
But you're right, there is still a lot of reluctance around feeding. And you were lucky that this person chose to not breastfeed. Well, it's not a good outcome, and but continue to take her medication. The commonest thing that happens is they will choose to breastfeed and
And
stop
go
taking
off
medication,
medication. Yeah.
and that becomes a mess because they're not well enough to breastfeed then. So that's a worse outcome, I think, for both mother and baby.
True. And the last point that is around labor management, which a lot of them are worried about. Actually, families sometimes more worried about than them is, can they handle the pain of labor? Will that cause an exacerbation? Often there's a request for a section also. But I mean, if we, usually we counsel them about pain relief options that are available, and per se, this need not be a reason for them to choose to have an elective section. So these are other components and that come in. And of course, there is we do screen everybody for gestational diabetes, but we do know there is a strong correlation between mood and GDM, and especially somebody who has a higher BMI who may have other metabolic comorbidities. In the preconceptional clinic, we should ensure that we don't forget about all the other stuff, because they could, high BMI, irregular cycles, she may already, her sugars may be high. So we do need to check, and thyroid, all of that also needs to be done in a comprehensive manner to ensure that she's well prepared for pregnancy.
Absolutely. So in summary, I think the main points we wanted to flag today was seek psychiatric consultation early, encourage collaborative care. And I know I've had actually more success with obstetricians wanting to collaborate than getting my psychiatric colleagues to collaborate. So please reach out and encourage collaborative care. And it's definitely getting better in the mental health side as well. Optimize symptom control and minimize exposure, and counsel them also on, because everyone comes with what are the side effects of medication. And now I've started talking to my patients about, can you tell me the side effects of illness if you become ill? And if they think about it, they're actually able to tell you the things they can't manage. So counseling about side effects of illness is also just as important as side effects of medication. And respect and encourage autonomy of decision making in the mother. Even if she has a mental illness, let's not assume that she can't make decisions, that she can't look after the baby. And recommend contraception strongly if they're not yet ready and they need medication management.
Thank,
Thank you so much.
thank you, Ashlisha. I
Thanks.
think
Thank you.
there is a question. Nivedita had a question on ECT, but Dr. Nivedita will take it after the next session, because I think that's going to be covered. But Sureka, you can ask your question on, you had a
Yeah.
comment on consent. Yeah, please go
Yeah,
ahead.
yeah. I just listening very carefully about decision and autonomy for decision making. But sometimes when women are on antipsychotics, especially, in difficult situations when we are taking consent and for legal matters later on, is this consent considered valid when women are on antipsychotics? And who is the person who will say she does have a decision making capacity?
So being on antipsychotics doesn't preclude them from having capacity,
Okay.
right? It is like if they were on anti-epileptics, we are not going to naturally assume that they don't have capacity. And capacity is usually decisions specific. So if you want to take consent for, say, epidural, then that you have to see if at that time, do they have the capacity to make the decision for consenting to pain management? Are they able to understand or not? Which might be very different to consent for taking contraception when they are planning pregnancy. So, and whoever is administering the treatment really should be making decisions about capacity in that moment. A psychiatrist can do an assessment and give you a baseline whether this person is well enough to be engaging in conversations around making different capacity consent, right? So they might not be able to tell you, yes, she has capacity to consent for contraception, yes, she has capacity to consent for C-section, because the nuances of that informed decision making, only the person who's delivering the decision will be able to do. But getting a psychiatric opinion to say, is she well enough to engage in conversations, multiple conversations that will come up during pregnancy and postpartum, in consenting for various things. So sometimes actually if they're on antipsychotic, they're more likely to be well and better likely to have capacity. So as far as I know, even medico legally, being on antipsychotics does not naturally assume lack of capacity.
But is it a good decision on the part of gynecologist to have a witness or, another family member also to sign the consent along with the woman? What do you think? Like
I'm not,
decisions for C-section and decisions for operative births, like that,
yeah.
where
So
the
what you
harm
can
may
do
be
is,
there. The
yeah, I think
risk is more.
yeah, I mean, I don't know. See, the difficulty you might have is you don't know, if you don't know the dynamics between the family member. Later on, the patient might come back to you and say that, I was coerced by the family member. Why did you take their consent? So I think the best thing is to work in collaboration with a psychiatrist who can say, look, she's well enough, and you can ask her to give consent. Even in that moment, like again, when we talk about psychiatric emergencies, we might say, like, let's say during labor, she's not consenting. And this is a common referral that I get sometimes. They are sort of not consenting. And often we raise questions about capacity only when they're not consenting. We rarely sort of, look for capacity if they're consenting. So we should be doing in both cases. But when they're not consenting is when you might, if you have the resource, to get a psychiatrist to evaluate, to see if their illness has taken over their capacity to consent. In fact, in some cases, which probably is not so clear in pregnancy, they may have schizophrenia. They may still have some delusions, but the delusions may not be related to their ability to give capacity. They're still many times able to give capacity because the delusions might be related to a long standing thing that's going on in their illness. So capacity assessment has to be done in the here and now for that particular condition,
Very
intervention.
difficult.
Very
See,
difficult.
we can have an initial
Thank
review,
you.
but that particular, situation, again, having reviews may be a little difficult. But definitely, I think the take-home message is primarily a review is important with the
Absolutely.
psychiatrist. And if the
Yeah.
psychiatrist has deemed that the capacity is okay as far as consent and decisions are there, then that will be considered as valid in a court of law as well if something goes
Yeah.
wrong.
Yeah.
Thank you, Aslesha madam and Umaram madam. I have one question. Yes, shared decision making is important, and we are offering that to a woman. But if she asks, will I be passing this disease to my offspring or to the baby? What do we answer, ma'am? Because that is a basic question they ask us. So,
Sorry, say that again. I missed that. Will I be?
will I be passing this disease to my child? So, what do I answer them?
Yes. No, so there is a percentage of risk of, and I think Shubhangi is going to cover a little bit of that as well. If she's, there is a risk of uh, inheriting psychiatric condition, but the risk is not only genetic, right? For all mental health conditions and possibly for others as well, the risk is a combination of interaction between genes and environment. So what I usually tell them is, you cannot decide the genetic risk. You are already born with it, and your child is going to be born with it. But what you can do, which you're already doing, is change the environment. So when you're improving the environment for the child, you are going to reduce the risk of them developing the illness, even if they're born with the inherent hereditary risk. So
Okay.
just because someone has the genes doesn't mean they will absolutely develop. If you
Okay.
improve the environment for them, you're reducing the risk.
Okay.
Yeah.
So,
Thank
ma'am,
you.
during
Thank
the
you for that.
spectrum of the disease, from the mild to severe, she is on treatment. So, during pregnancy, because of the hormonal changes or comorbidities, the severity might vary. So, are there any scoring systems, or is there any way that we can find out that this woman is going to get severe and we have to be more careful and she needs different treatment? Can we have a
Yes.
judgment on that?
Well, one of the commonest thing is how severe she's been in the past,
Okay.
and what are her relapse indicators. For some
Okay.
people, lack of sleep leads to a relapse. For some people, interpersonal violence leads to a relapse. Psychological stressors leads to a relapse. For some, so it's different for different people, and helping them to recognize their early warning signs, their relapse indicators, their particular stress points will tell you these are the things to avoid. So
Ma'am, what
it's
about
individual
suicide?
based.
Think we will address some of that in
Tendencies?
the
Will they get severe during
psychiatry.
pregnancies?
So I will address that in the chat. You're
Okay.
you're talking about suicide risk, and I will
Yes.
I will address that in the chat.
Okay. Thank you so
Yes.
much.
Just
Thank
in
you
the
for the
interest
We
of
need to go to
opportunity.
clarity.
the next talk, and I think Nivedita can take over as the chairperson here.
Nivedita,
So
yeah,
that's
Nivedita, welcome.
yeah. Thank you very much for this opportunity. And I have been here day one and day two. So it's been very, not just I like perinatal psychiatry. I have been doing quite a lot of work. But after this workshop, I feel that we have to integrate more and do a nationwide project. Multiple projects can be done when a mother comes. thinking that she'll have a normal delivery and baby goes to nursery. So such women we find they get they are, it's very difficult to manage them, and we discharge them and they come back with more depression. So further, I mean, this is really so useful. So now our next talk is going to be on depression and anxiety in pregnancy. So for that we have, can I have the slides, please?
Yeah, it's coming on screen. Next slide, please. Yeah.
Yeah. So it's my pleasure. No, it's not Dr. Sudha Sharma. It's no. It's
The
the one.
chairpersons are same for the session 1.
Yeah.
So
The next speaker.
I'll request you.
Yes. Next speaker is Dr. Shubhangi Dere from MGM Hospital, Mumbai, and she is a trainer on perinatal mental health in collaboration with UNICEF and Jopaigo. So enormous publication and tremendous work in the field she's been doing. So we are honored to have you, Dr. Shubhangi. And the other speaker for the second talk is Dr. Runa Benjamin. I had heard her on the day one. Madam is consultant at Sitapati Clinic and then avid consultant in RCOG. So welcome you both.
Thank you so much. Thank you, Dr. Nivedita. Now they will be carrying on the torch further. The patient is pregnant. Now they are going to discuss depression and anxiety in pregnancy. How to check it. Over to you, ma'am.
Welcome, Dr. Aruna Suman.
Thank you, ma'am. Thank you so much. Thank you for the opportunity.
Runa, do you want to turn on your camera?
Yes. Yeah, good afternoon. Is it on? It is on.
Slide.
Yeah.
Okay.
So.
Dr. Runa, you can start.
Okay, good afternoon, everyone. So this talk is going to be on anxiety and depression in pregnancy. Dr. Shubhangi and I will go through a couple of cases. So anxiety is defined as a feeling of worry, nervousness, or unease about something with an uncertain outcome. Women have a strong preoccupation or concern to do something or for something dreaded to happen. It's quite common in pregnancy, more common than depression, with an incidence of 4 to 54%. And prenatal anxiety disorder is one of the strongest risk factors for developing postnatal depression. So, Dr. Shubhangi, what are the other types of presentations of perinatal anxiety disorders?
So apart from what we usually see is pregnancy-specific anxiety, you will be seeing women with coming with a lot of anxiety related to the pregnancy as such. The first trimester will have different worries, and the third trimester will have different worries. The postnatal period may have different worries. So these are all normal pregnancy-specific anxieties, but we are talking about anxiety disorders. There are specific types of anxiety disorders that we come across in perinatal period. So it is usually, as you can see, generalized anxiety disorder, panic disorder, phobias, obsessive compulsive disorder, and post-traumatic stress disorder. So these are usually various types of anxiety disorders which are also common in perinatal period. Let's see one by one. So generalized anxiety disorder is the most common presentation that we come across in perinatal. As the name suggests, it is like excessive, recurrent, uncontrolled worries about many things, about small events happening around in the perinatal period. And these worries are significant enough to cause functional impairment in their motherhood role. So the themes usually have around fear of fetal well-being or handicap, whether my child is going to, the fetus is going to be healthy, or whether it will have any handicap, or whether the delivery will go right or wrong, normal pregnancy, normal delivery versus cesarean section, the self-image, I have gained a lot of weight, how do I come back to my original personality, my hair loss is too much, all those things, whether I'll be a good mother or not. So a lot of themes of worrying nature. Then there can be worries about the household things, about well-being of family members, the financial worries, which is very also very common worry in perinatal period.
Prevalence is varied, but you can see that the pregnancy carries the prevalence of 10 up to 10.5% and postpartum the same. Usually, these worries are misdiagnosed because what we come across is not the thought, but they come up with a lot of fatigue, they come up with a lot of pain or vague somatic symptoms. And then we misunderstand is that the physical symptoms of anxiety. The fatigue could be because of pregnancy, third trimester, the pain could be because of this, but a lot of somatic symptoms are the presentation, the cognitive symptoms are missing. And the most common comorbidity along with this anxiety is depression, which is very common. Anxiety disorders in pregnancy, they predict threefold increase in the development of postpartum depression, as they have already heard about it. And a lot of women engages in addiction to relieve their anxiety. If they're already taking alcohol, the consumption might increase. Then coming to obsessive compulsive disorder, as the name suggests, they have obsessions and they have compulsions. The predominant obsessions are horrifying, intrusive thoughts of harming the newborn child, unwanted images of throwing or dropping the baby, or sexually abusing a child. The mother may just have a glimpse of baby falling from her hand, or maybe she's touching the baby inappropriately. So these are the common obsessions. And then the common compulsions are hiding or throwing sharp objects because fear that they might harm the baby because of avoiding childcare. They just avoid holding the child or touching the child with the fear that they might abuse the baby. They constantly keep reassurance, seeking reassurance about from the relatives that whether they are doing it rightly or not, whether the baby is fine or not. Monitoring self for perceived inappropriate sexual arousal, touching the baby and constantly checking if they are sexually aroused or not. I had one patient, she on the day two of postpartum, she was avoiding looking at the baby because she thought whenever I look at the baby, I should smile, and if I'm not smiling, I'm not a good mother. So she was constantly checking about her bond with the baby, and if it was not happening, she finally decided to pinch the baby and see if the baby is crying and I'm feeling guilty about it. So she pinched the child. The child started crying. The unit started crying, and she didn't feel anything. So she was so upset about it. The obsessive thought was exaggerated that I'm not a good mother because I'm not feeling guilty of what I did, or I'm not feeling bond with the baby, and that was it led to a lot of chaos in the hospital. Then they usually undergo shame for having such horrifying thoughts. They feel, fearful to be misunderstood, and that's why they don't talk about this obsession. They feel very awkward about it, and usually this condition goes unnoticed, untreated, but it leads to a lot of poor quality in their perinatal period. Their functionality gets restricted. Their health deteriorates in general, and the relationship with the family members also deteriorates. I also had another patient who had obsessions of contamination, and then she used to just, not allow her baby to be held by anyone in the family, and that led to a lot of strained relationships in the family. Then another common condition in perinatal period is post-traumatic stress disorder. So as we know, it leads to a lot of autonomic arousal. They have a lot of autonomic symptoms like palpitations, restlessness, breathing difficulty, then a lot of aches and pains in the body, disturbed sleep, and they're constantly on the edge. With the smallest of the small sound, they're, alarmed or triggered, startled, and they're not able to relax. So the common etiology behind it, or the common comorbid conditions around which the PTSD develops, is having a baby with physical morbidity, or baby in an ICU post delivery, and they're not able to see the baby, or they are seeing the baby in a lot of tubes and IV lines and everything. Poor communication or lack of support and reassurance during the delivery. We had been having patients who went into PTSD with simple procedures like, C-section. It was not well communicated, or the decision was so hasty that the communication didn't happen. The woman didn't know that she's undergoing C-section. So all these hassles in the last moment led to a lot of PTSD symptoms. Then pregnancy arising out of sexual trauma, physical complications or injury during operative delivery like prolonged labor with hematoma and all these things can lead to PTSD. Strongest predictor of PTSD is anxiety occurring late in pregnancy. The woman who is having a lot of anxiety symptoms in the third trimester is more vulnerable to develop PTSD if she has any of these condition in her labor. And again, it is associated with depression. So these are in general most common presentations of anxiety.
So moving on to the case, we'll go over the impact of anxiety on the perinatal period, implications of anxiety, and the management of anxiety. So this is Mrs. N, 35-year-old, fourth pregnancy. She's had 3 miscarriages before. Nil significant medical history, and surgical history included a laparoscopic ovarian drilling and a diagnostic hysteroscopy. This pregnancy was an IVF conception, di-dyed twins. She was very anxious due to the previous 3 first trimester miscarriages and the IVF. She had regular antenatal checkups, and a scan at 21 weeks showed cervical incompetence. She was admitted for the procedure, and after the procedure, she was discharged after 2 days. Now, post-discharge, she came in multiple times to the hospital with complaints of watery discharge. And at every visit, she was examined, assessed, reassured. And at 23 weeks, she developed GDM and was started on insulin. So now, is this level of anxiety normal, or is this pathological? And how do you differentiate between them?
Yes, the normal anxiety is what we all have. These symptoms you will always see in a pregnant woman that will be concerned about outcome. She will constantly seek reassurance. But how do we differentiate with a pathological anxiety? Is based on its intensity, persistence, and its impact on the functionality. So if the symptoms are intense enough that they are felt very intensely by the patient. So it's usually that we ask them that, have you been having lots of worrying thoughts of lately, to an extent that you cannot stop worrying for? Okay, so it's an intensity. Persistence is they're persistent all across the domain that they're worried when they are resting, they're worrying when they are engaged in any entertainment, they're worrying when they are talking to their friends. So all the domains of their life, personal, social, professional, they're constantly worrying about it, and they're not able to let that thought go, and it is severe enough to cause an impact on their overall functioning. So they're not able to sleep, their appetite is hampered, they're not able to concentrate or focus, they're not able to maintain relationships. So this is how we differentiate between normal and pathological. And that is what, if it is severe interfering, it is obsessive thoughts. They also don't uh, accept the thought or agree to the thought, but they're not able to stop the thought. And if there are secondary helplessness or hopelessness about it, or feeling guilty about having such thoughts, it's a red flag that it's not no more a normal anxiety. It is definitely a pathological anxiety.
So then she presents at 28 weeks with extreme anxiety. She was breathless. She said she was not able to stay in closed places, and she hadn't slept for 3 days. We referred her to a psychiatrist, and she was started on sertraline. And the patient didn't take it because she was worried about the effects of the medication on the baby. Now, this is one of the commonest things that we see, where they don't take it because they're like, it's going to harm the baby. At 30 weeks, she came in with palpitations, breathlessness, weakness over the lower limbs, and feeling very claustrophobic. She was sent to a cardiologist to rule out cardiac causes. Vitals were stable. She had tachycardia, so she started on metoprolol, and she was admitted in the obstetric unit. She said she felt much better in the hospital, and she started on zolpidem. So now, how does anxiety affect the pregnancy? Now, she's only 30 weeks. We still have a minimum 8 weeks to go. So how does this affect the rest of her pregnancy? And what are the effects on the newborn? The medications on the newborn as well.
Yeah, Dr. Runa, you can, we all can see that how anxious she is, constantly making visits. She's having symptoms, simulating a cardiac condition. She's not able to relax. And the another proving fact that she is feeling assured and she's feeling relaxed only in the obstetric setup when she's admitted, she's under supervision. So all these things hint towards the anxiety that, she's going through a lot of anxiety. So it is obviously going to affect her pregnancy outcome. So, what do we see in research or in our evidences till now is perinatal anxiety does impact on fetal outcomes, obstetric outcomes, and neonatal outcomes. If there is a persistent severe anxiety, it leads to a lot of fetal tachycardia, IUGR, small for gestational age babies, and increased fetal activity in the later trimesters of the pregnancy. Then, on obstetric outcome, we see that preterm labor or birth is very common, low birth weight babies are common, increased risk of operative complications we see. Then neonatal outcomes are also hampered because of it. where we see that the babies are show poor neonatal adaptation. They are having more irritability. They are more cranky. They are difficult to care for. They are very jittery and they have a lot of sleep disturbance. So all these complications are very common if the anxieties are treated during the antenatal period. And when we talk about long-term impact of anxiety on the mother and the baby, we see that it hampers the brain-derived neurotropic factor because it is a kind of inflammation to the brain. The heightened anxiety, heightened stress is like an inflammation, and it negatively impacts the neurodevelopment of the fetus. The infant, they who are born to the mothers who are anxious, they appear to be withdrawn, and they are more likely to display lower emotional tone. So they don't engage emotionally with the mothers. The children may have increased risk of ADHD when they are followed up till the age 7 years of age. And adolescents of mother with high levels of anxiety anxiety, they show deficits in cognitive control. So the same cognitive emotional regulation deficits are carried forward in the children also. So this is very important point to know.
What are the treatment options available? Do we do anything else other than oral medications?
Okay. Yeah, so very important question. So when we talk about anxiety, which is very common and we can't, afford missing the cases of anxiety. What do we do when we diagnose them? So we have to basically categorize the anxiety in mild, moderate, and severe cases. Okay, mild to moderate cases can definitely be managed with non-pharmacological intervention, which includes psychoeducation, peer support group, then cognitive behavioral therapy, which is more scientific and tried and tested interventions for mild to moderate conditions, where we focus on their faulty cognition, which is leading to a lot of anxious distress. So we tap their maximization of problems, then selective abstraction, or a lot of cognitive traps are there. So we highlight those to them and we work upon them to come to a more rational thinking, which reduces their anxiety. Then other group therapy is interpersonal psychotherapy. Along with that, we also focus on their behavioral management where we talk about relaxation exercises, yoga, deep breathing exercises, mindfulness, and working upon their lifestyle also, having a good sleep, having a good diet, avoiding panicogens like cold remedies or a lot of beverages, hot beverages, or avoiding things which usually causes a lot of acidity because acidity is also one of the trigger for increasing anxiety symptoms. So if all this management, all these interventions help in mild to moderate, but in severe conditions, we have to take help of psychopharmacological therapies, which is primarily selective serotonin reuptake inhibitors, benzodiazepines, and Z1. So these are the proven therapy options for the anxiety.
So what are the implications? So now that we've talked about the pregnancy, the rest of it, implications in the postpartum period?
Yeah, definitely. So we saw the impact on the baby. Now we see the impact on the mother. So mothers who have generalized anxiety disorder usually see they are quite preoccupied with the negative thoughts, the negative cognition, and the interpretation of their bodily symptoms. If somebody is having palpitations, breathing difficulty, they'll be so helpless and feeling so, worried about. So when they are so preoccupied with their anxiety symptoms, they are less responsive and less engaged in interaction with their infants. So they don't enjoy the bond. They're less likely to identify the happy faces of the infant due to excessive worry. So these mothers they usually be in a negative tone of motherhood, and they will not enjoy their role. They will be less satisfied out of the interaction that happens, and they will be more preoccupied about what is going wrong. So the mother-infant bonding gets hampered, and in postpartum period, they may report sexual fear, avoidance or body image, self-consciousness compared to those without anxiety. So we must have heard, all the participants must have heard about tocophobia. So women who have tocophobia also fear the sexual contact because they don't want to get pregnant again. They would want to avoid second pregnancy, and because of which there can be a lot of relationship difficulties in the future. And again, PTSD.
So, in conclusion, anxiety disorders like GAD, OCD, PTSD are often common and often misdiagnosed because a lot of their symptoms can present like pregnancy symptoms. Anxiety and depression sometimes occur together and they are present in pregnancy and persist if not treated. Untreated anxiety can cause long-term serious implications on the baby and for the mother. Screening for anxiety is important as it has clinical benefits. Detection and management of antenatal anxiety can improve pregnancy outcomes and identify women needing additional postnatal supervision. Moving on to depression in pregnancy. So again, in terms of the prevalence, it's about 11% in the first trimester, 8% in the second trimester, and it's highest in the postpartum period. So this is roughly about 1 in 10 women who come to the antenatal clinic that will have depression.
This slide is very important because if you can see the prevalence of depression is high throughout pregnancy and till 1 year postpartum. So the depression and anxiety almost shares these figures, and it is very important to know that they can erupt anytime till 1 year postpartum.
So moving on to the case. So this is a 28-year-old lady who had a section 2 weeks ago and has come in for her first review. She was keen on a vaginal birth, but due to non-progress of labor, she had a cesarean section. So baby was roomed in immediately and postnatal period was uncomplicated. Baby has gained weight, doing well, her sutures are well, so she is well generally. But she says she's not feeding the baby well enough, and her mother says she's not eating well. And further questioning, she says she hardly gets 2 to 3 hours of sleep and generally feeling very tired. So now the question is this postpartum blues, which we normally see, or is this postpartum depression? And how do you make the difference? How do you differentiate between them?
Yes, definitely. It's a very important question when it comes to postpartum depression. We all know that postpartum blues are mild mood symptoms. They're very mild symptoms and they resolve on its own. It resolves abruptly. It doesn't need much intervention. It just need a normal reassurance and a support. So mild symptoms lasting up to 2 weeks or less and usually resolving spontaneously without any sequelae onto their functionality is postpartum blues. But here what we see is a severe and a persistent mood symptom along with impairment in their functionality. They're not able to sleep. She's not able to eat. She's feeling tired most of the days and she's not feeding the baby. So here we see that the mood is affecting her overall biological rhythm as well as her role as a mother. And that is why we cannot miss this as a postpartum depression. Considering this as a postpartum blues, and we have to be suspicious about the postpartum depression.
So, what symptoms will she display if she has developed perinatal depression? And do blues and depression affect mother-infant attachment?
Definitely. So what we see is, like I talked about, parental depression is a very distinct entity where the symptoms are just like a major depressive disorder, where we have mood, predominantly the mood symptom, that feeling low, lack of interest in most of the activities. And along with these two cardinal symptoms, we have a lot of other symptoms, say disturbed sleep, either sleeping less or more, disturbed appetite, either eating less or eating more, decreased sexual desire or increased sexual desire, then decreased concentration, feeling tired or having somatic symptoms, and having suicidal thoughts. So out of this, if four symptoms are there, out of which two cardinal symptoms has to be there, then this is definitely a perinatal depression. We have a lot of scoring system available. I'm sure you all have heard about the scales that we use. So we have to ask for all these cardinal symptoms. Along with this, if we could ask about her mood, okay, this was not asked in the history, that we can simply ask her in last 2 weeks how your mood has been. Okay, so the quality of the mood. If she comes out with the mood saying that I'm not feeling good, I'm not feeling enthusiastic about what is happening around, it simply shows that her mood is dull. And secondly, what we can ask is she having interest in her day-to-day activities or her roles throughout the day as she used to have it before. So if the interest is reduced, her mood is reduced, we can further go and dig into her cognition. Either she's feeling helpless, hopeless, or worthless. So these are the three important cognitive symptoms that hints towards perinatal depression. So feeling helpless is a feeling that nothing good is going to happen. Feeling helpless is nobody can understand my situation, and anyways, nobody can help me out. Hopelessness is nothing good is going to happen in the future. It's going to be continued in the same way. And worthless is I'm not a good person. I'm good for nothing. I'm having this problem. I'm not going to improve. So if these three cognitive symptoms are there, it is definitely a depression. Coming to the second question, postnatal blues and depression affect mother-infant attachment. I will say postnatal blues does not affect attachment so much because it is a very mild symptom and it resolves. It doesn't continue beyond a particular time. But depression, coming to depression, it definitely has a negative impact on the mother-infant bonding. So it significantly influences the mother-infant bonding. See, for having that bonding, the mother has to spend a exclusive time with the baby, looking at the baby, holding the baby, feeling the touch, the warmth, feeding the baby on demand, and enjoying the process of being with the child. So if the mother is feeling so helpless, hopeless, worthless, tired all the time, having no mood, no energy to do anything, she's not rested adequately, obviously her bond with the baby is not going to be good. And depression, substance use, and higher anxiety levels are associated with lower levels of mother-infant bonding. Let me tell you that depression and anxiety are not watertight compartments. It is these two conditions are quite commonly present together. So if you ask me, depression will have high comorbidity as anxiety in 70 to 80% cases, and anxiety also will have a comorbid depression because the cognition plays the same role in both the kinds. Also, coming to the breastfeeding, Dr. Runa, you will also agree to it that when the mother is depressed, the breastfeeding gets hampered. Okay, so postpartum depression may reduce the rates of breastfeeding, and also they don't engage with the baby through the process of breastfeeding. And also, if there are breastfeeding issues, if the mother is having problems with the lactation, it is one of the important risk factor for development of postpartum depression. So there is a bidirectional relationship between them.
So then what are the effects of untreated depression? Because a lot of times the women are told at home, well, this is what normally happens, you'll be okay, it'll get better. So if they're not brought in and they're not treated, what are the effects there can be?
Yeah, very important point to understand here that if the treatment is not done, the depression is not intervened, it can lead to a lot of effects on the mother as well as the baby. First of all, if the mother is depressed, she will not look after her antenatal care. So the inadequate antenatal care will lead to a lot of obstetric difficulties and the fetal difficulties. Then poor nutrition will lead to lower weight, preterm deliveries, operative complications will be there. Then preeclampsia. It is a generally accepted knowledge that the pregnancy is not protected with regard to the new onset or relapse of MDD. So the mother has a history of depression or anxiety. Pregnancy is a vulnerable time for relapse. And even if there is no history of MDD in the past, major depressive disorder in the past, pregnancy is a period where there can be a new onset of depression. And usually, suicidal tendencies are high. So I will cover it up in the next session. But if there is untreated depression, it will definitely have a negative health-related behavior and increased risk of suicide. Also, women who experience antepartum depression, there are high chances that they continue depressive symptoms in the postpartum period. So the history of untreated antepartum depression or high amount of anxiety is a risk factor for development of postpartum depression. The risk is up to 50%. And terminating antidepressant treatment in pregnancy in women with a previous history of depression leads to relapse of symptoms in as many as 60 to 70% of women. So we shouldn't be abruptly terminating antidepressant medication just because she's got pregnant. We have to take a psychiatric review whether the drugs are safe or not, and we can maybe rationalize, optimize the treatment. As Dr. Ashlesha pointed out, we may come out to one medicine and continue the medicines because better to have controlled symptoms than a relapse of symptoms. And uncontrolled, yeah, that is already been covered. Right.
So what are the treatment options in terms of postnatal depression other than medication?
Yeah. So again, the treatment management protocol goes as same as anxiety. So mild to moderate symptoms, we may offer them psychotherapeutic intervention to avoid the risk of medication exposure. But if it is a severe symptom, a combination of both psychotherapy and medication is the best. Now coming to postpartum period, women with postpartum depression are likely to respond to standard antidepressant therapy. And let me tell you, all the SSRIs are definitely safe in the postpartum period. So the amount of medicines that is secreted in the breast milk is very low. It is beyond traceable value. So in postpartum period, it is definitely considered to be safe. And there are very few adverse events or lower undetectable plasma levels in sertraline, paroxetine, fluoxetine. So these are the preferred medicines, out of which sertraline is the most commonly preferred medicine because that is also considered safe in the pregnancy. Whereas paroxetine carries a caution that it has to be avoided in the pregnancy. Then electroconvulsive therapy. Sometime back we were discussing about what if the woman has received ECTs, whether to continue pregnancy or not. Let me tell you, ECTs are one of the safest treatment modalities in the perinatal period. It is one of the safest option and having minimum side effects or adverse events on the pregnancy outcomes also. Obviously, in pregnancy, we consider high risk for ECT when they have a threatened labor or having any pregnancy complications. But otherwise, if it is a routine pregnancy without any pregnancy complications, having a severe depression with suicidal ideation, ECT is considered very safe. In the postpartum period also, ECT is considered very, very, very safe.
So if we give them medication antenatally, is that will it prevent depression postnatally?
Now coming to prevention, more than treatment, I will emphasize on identifying the risk factors for the prevention. So as Dr. Ashlesh has already talked about in our previous session, along with the biological risk factor which is beyond our control, we have a lot of other risk factors which are quite modifiable. So we have socio-demographic risk factors like young age, unemployed, low socioeconomic status, or poor education status, having a poor relationship with the partner, intimate partner violence, or poor support from the family. Woman who has a lot of anxiety in her personality, or previous history of depression, or history of childhood trauma, adverse life event, or recent significant life events in the perinatal period 1 year before that, or personalities who are very anxious, having low self-esteem, or personalities who are very dependent, or somebody who is having a lot of emotional dysregulation in their personality. So, which we typically call it as a borderline personality disorder. These personalities are very prone to develop depression, especially in the perinatal. Also, obstetric factors where, this is also one of the important risk factors, unplanned pregnancy. Okay, so woman, if she's not ready, if she's not prepared to go ahead with the pregnancy, it's one of the risk factors to develop depression in the perinatal period. Pregnancy complications in the past, or maybe a negative parental outcome, somebody who had IUFP, somebody who had mid-trimester abortion. So such women are to be protected, or they are to be taken more care during the subsequent pregnancy. So it's very important to ask them about their past history of psychiatric illness, their vulnerability, and to protect them through support, reassurance, or psychotherapies. We can start them early to give them psychological support. We can ensure more partner involvement into her perinatal period. We can ensure that the family is supportive. We can make sure her obstetric care plan for the next 1 year, and that is how we can protect their occurrence of depression in the pregnancy or postpartum period. However, we can still think of prophylactic treatment if the woman is known case of major depressive disorder. So here, if she has been better in the past, and now we know that she's having a significant stresses in her life, she's having a lot of complications in her pregnancy. First, we offer her psychotherapy to her, and if there are emergence of symptoms, even if mild symptoms, we do start treatment for her, which will prevent a relapse of the symptom in a full blown way.
So to summarize, it's very important to take a thorough history, past personal history and a family history as well, psychiatric history. Multidisciplinary team approach is best to maximize outcomes. As we've heard in previous talks, limit the number of drug exposures for the baby, and consider active depression in the mother if there is an exposure. Prescribe medications with the best documented evidence, and if a baby was exposed to a medication during pregnancy, it may not make sense to discontinue it afterwards, because like Dr. Aslesha said, very low quantities go in the breast milk, and discuss psychotherapy as a treatment option. Thank you.
Thank you. Thank you, Dr. Shubhangi and Dr. Runa, for that nice crosstalk. Ma'am, you have left no stone unturned, rather. So I'll request chairpersons to kindly ask their questions directly, because I find some interesting queries posted by some chairpersons. So should I read them?
No,
Yes.
I'll ask
Surita?
them.
Yeah,
Thank
yeah,
you,
yeah.
Dr. Anita. Wonderful crosstalk indeed between, and this is a really good model of doing online sessions. I think they are very interesting as well. So my question was, I have two questions, mainly about screening for anxiety and depression. So should we be doing a universal screening for all women? We are having one project with UNICEF regarding this, that we should be screening all women, so that, because many a times they may not, we may not know whether a disorder exists unless we screen, isn't it? And if you want to screen during pregnancy, then at what gestational age should we do if you want to do one screen? And of course, in postpartum, should we repeat the screen? That is my question. And then the later question I'll ask after
Um,
this
in
is.
our antenatal clinics, we do them at booking. So when they come in, we go through a medical history, we go through an obstetric history. The same way, we also go through a mental health history, and we have a questionnaire to screen for depression and anxiety. So we do that, and if they score on those questionnaires, then we kind of refer them on to the psychologist or the psychiatrist, and we follow them up when they come back for their next visit as well.
I
So
will
you
share what I
recommend a universal screening? All women
Yes,
should screen?
yes,
yes, yes,
everybody.
definitely. Because
Okay.
anxiety and depression is so common that we can't miss them, diagnosing. See, severe mental health issues are visible. You can make out it's a spot diagnosis. If the woman is psychotic, it's not difficult to identify. But if the woman is anxious or depressed, it's very difficult to identify unless you're not looking for it. Okay, so that is one. Secondly, not all women are comfortable talking about it in the ANC visit in that much of crowd, or somebody being there with them. So it's important to screen for this. So what I have done in Maharashtra district along with UNICEF is we have
Yeah.
used two item GAD and two item PHQ, where their basic mood symptoms and anxiety symptoms. As I said, cardinal symptoms of depression: low mood and decreased interest, and cardinal symptoms of anxiety: excessive worries about very small things and not able to control the worries. These are very simple questions. And what do we have recommended is, at the time of booking, more than the question, what we emphasize is on risk factor assessment. There are 7 risk factors that we have streamlined. So risk factor assessment gives us a caution about this woman being vulnerable towards development of symptoms. Okay, so once we do the risk factor assessment, then further second time risk factor assessment will be after postpartum. So once at the time of booking and after the delivery, and the symptom assessment will be at the time of third trimester and postpartum. Okay, so this is how we have done the timeline of
Yeah, it was in Nasik district. I think I did see
Yes, yes,
the
ma'am. Yes,
Marathi translation of the GAD
yes,
score,
yes,
which
yes.
you had.
The
Wonderful
tools
indeed.
were obtained from them hands, and we did the Marathi translation.
Yeah, yeah, I had a opportunity to look at that tool when UNICEF was sharing with us.
Yes.
And this, my second question is, when we talk of antipsychotics or anxiety drugs like quetiapine, we talk about neonatal the risk of neonatal adaptation syndrome if the dose is high in the third trimester. So we consider that the dose should be reduced and probably. So what is the protocol for reducing this medication so that this neonatal adaptation syndrome risk is reduced, and versus maintaining the dose to prevent postpartum relapse? So if you reduce too much, the possibility is a relapse. So are there any protocols or um,
Yes.
uh, for
Definitely,
this?
the treatment guidelines emphasizes on using minimum medicine in a rational dosage. So we cannot go very low that the woman may have relapse, or on the other hand, we cannot use polypharmacy to suppress the relapse. So it is rational to use minimum medicine along with the optimum dosage. Okay, so if you really ask me, the treatment of depression in perinatal period requires the same dosages as we use it otherwise, non-pregnant women. Or treatment of OCD in parental period requires the same high dosages of SSRI as it is required in the other non-perinatal period. the treatment uh, guideline says that. Also, in terms of certain medicines like lithium, we have to titrate the dosages around the perinatal, I mean around the labor. So before the labor, because there will be loss of volume, we have to stop the lithium. Once the baby is delivered, then we have to restart. But between this period, we have to substitute it with some antipsychotics so that the symptoms are controlled. So this titration is required, and it's very, it's very important that a psychiatrist is there on the panel, because all these small changes would be monitored, and it will be ensured that the woman is in non-relapse condition or a maintained condition.
Yeah, thank you. Over to the other chairpersons
Yeah.
before I ask my
Thank you,
third question.
Sarojini. Yeah. Aruna, you want to make any comment or any queries there? Or Dr. Nivedita, you are requested to kindly make a comment.
Yeah, I just have one question. As obstetrician, are we allowed to prescribe any anxiety? Patient says she's having palpitation, she's scared of the pregnancy, and we think that okay, she might be having anxiety. So, is it allowed? Because many times we have seen patients prescribed Nexito by obstetrician. So, is there any recommendation or anything? I wanted to hear from experts.
See, you can definitely prescribe. It's not that you cannot prescribe, but what we emphasize is make sure about the diagnosis. Okay, because we should be sure what are we treating for. The symptoms are, they're very confusing. Overlapping symptoms are there. Also the dosages. So what we come across is the patient is diagnosed as anxiety and started on Nexito 5, but the dosages are never increased and they are not assessed henceforth about the cognitive symptoms. They may have OCD in the background, or they may have a mood disorder in the background. So what I will advise you is you can start. There is no problem, but once you find out such patients, which are not very common patients, make sure that at least they are seen once in the pregnancy and once in the postpartum by a psychiatrist in the locally available area. It is advisable, okay, because the cognitive part is difficult to be understood by non-psychiatrists. We are
It's,
trained to take that mental status examination, the thoughts, the perception abnormalities, the
yes.
content of the thought. So all those minor details will be assessed by psychiatrists more rationally than a non-psychiatrist. But you can definitely start, ma'am. It's not that you cannot start. So
Yes, but
equilibrium certainly
Shubhangi ji,
final
has
there is
call.
another. Yeah,
Yes, final the
Shubhangi ji,
expert call.
there is another aspect of this. Once an obstetrician starts any
Ev-
kind of treatment, the
Everybody must
symptoms may
start
get
that.
suppressed, or it may get changed. So it is always better that the initial phase only we consult a psychiatrist for
yes,
exact diagnosis, as
that's the ideal
highlighted by
scenario.
you.
But
Yes,
but
Yeah,
always after excluding the organic causes, then only we
yes,
think of the psychiatric
definitely.
definitely,
diseases.
Yes, yes, there
definitely.
are some common diseases like encephalopathy or
Yes,
sepsis with advanced maternal altered status.
yes,
We must rule out that. That's very important.
yes.
Yes,
Before
definitely.
coming to the
Anxiety
diagnosis
also,
of psychiatry.
anemia, hyperthyroidism, all these things has to be ruled out first, and then
Definitely.
a
Yes,
psychiatric
We'll
evaluation.
go over that in the next talk, but
Yeah.
I think one thing is, as obstetricians, we see this patient, we think we've ruled out organic causes, and then we're like, right, it's either anxiety or depression, or I'm not quite sure. Talk to a psychiatrist. Have a friendly psychiatrist on speed dial. Talk to them and say, well, I've seen a patient like this, and it would be ideal if the patient can directly see the psychiatrist. But if they're not able to, it's the weekend, they've not been able to get a appointment with the psychiatrist, speak
mm,
to them and then start it if you're not comfortable doing it on your own. You could possibly
okay,
start them on sertraline, for that night, and then you say, well, within the next
okay.
24, 48 hours, go see the psychiatrist in the morning.
That's a good take home
Absolutely.
point you have given us, Dr. Runa. And one more
Yeah.
thing is post traumatic stress disorder. After the woman is coming out from the critical care, so when do we refer her to a psychiatrist?
No, as soon as possible, if you are thinking that she is at risk, as
Yeah.
soon as possible.
Okay,
Because we cannot wait for the symptoms to develop and then convince them, because then it becomes very critical.
okay, right.
Thank
Thank you.
you, Dr. Aruna. Thank you,
Thank
Dr.
you.
Dr.
Sureka.
Archana has a
And
question. I think we should address that also. Dr.
yes,
Archana Saxena, she has posted this. Is it necessary to separate the baby from the mother for safety of the baby in severe PPD?
No, it is definitely not necessary. See, what only a single red flag that allows us to separate baby from mother is thought of infanticide. In all other possibilities, we should not separate the baby from the mother. Even the Mental Health Care Act, which we are following for all psychiatric treatment guidelines, it says that baby up to 3 years of age shall not be separated from the mother unless the mother has any homicidal or infanticidal. Okay, so if that specific risk is there, then only separate. Otherwise, PPD doesn't recommend separating from the baby. In fact, separation from the baby will be itself a risk factor for her to feel hopeless and helpless. But again, there has to be a support system. So it cannot be left alone with the mother. There has to be an alternative support system. There has to be a co-sleeper. There has to be somebody who looks after the well-being of the mother as well as the baby. Thank you, ma'am. Some of the delegates have again requested to post link for screening tests for mental health. So we had already discussed on day one, but if you have the link, ma'am, please share in the chat box for the benefit of our delegates. So thank you so much, all the chairpersons, Dr. Surekha, Dr. Aruna, Dr. Nivedita, and our dear speakers, Uma Ram ma'am, once again. Dr. Shubhangi, Ruma, Benjamin ji, thank you so much for that wonderful discussion. Now I'll hand over the session to my co-coordinator, Dr. Shashilata Kabra. She'll be dealing with the next session, session 2 on psychiatric emergencies and doctors for self-care. Over to you, Dr. Shashi.
Yeah, good afternoon. Thank you, Dr. Anita Razoria. And I would like to wind up the presentation by saying that depression and anxiety during pregnancy are more common than many realize, and they deserve open, judgment free conversations. Supporting mental health at this stage is just as important as physical care for both mother and the baby. With timely help, understanding, and compassion, recovery and well being are absolutely possible. Let's keep the conversation going and going, and no one feels alone. So, with that, I move to the next session. Our chairpersons are Dr. Sudha Sharma. Dr. Sudha Sharma is there. Ma'am, welcome, ma'am, and please display the slide of Dr. Sudha Sharma. Ma'am is MD FICOG and former professor at the Department of Obs and Gynae, GMC, Jammu. And ma'am had been the vice president of IMS 2026-27. There are many more accolades.
She is currently the president.
She is currently the president of
President
our
of IMS, national.
Yes.
Okay. And very
Thank you.
dynamic. So many activities going on under her.
And Madam is also the Secretary General of NIGF. NIGF is a conglomerate of 7 or 8 states of North India. Am I right, Sudha ma'am?
Yes, thank you.
Yeah,
Thank you so much,
welcome
Dr.
you.
Shashi and Dr. Sheila.
Yeah. And Dr. Harish Joshi has shown his inability to join. So I request, and even Dr. Usha Sharma is traveling. So I request Dr. Aruna Suman to chair the session. And I can see Dr. Lakshmi Srikhande ma'am. Lakshmi ma'am, you are there?
Yes, she is there. We can request
Very
her
much,
to share.
very much. I am here. So I request you to chair this session.
Welcome.
So the first talk is on psychiatric emergencies, and the talk will be taken by Dr. Shubhangi Dare and Dr. Ruma Benjamin. They have already been introduced. So over to you, ma'ams. Dr. Runa, Dr. Shubhangi.
So thank you so much, Dr. Shashi, Dr. Sheila Mane, and congratulations for organizing, such an important subject. So thank you for inviting me. And we all know that psychiatric emergency is, little different from all other emergencies, as these patients can, harm themselves as well as they can harm to the others. So they are a, potential danger to the society. So what are the problems? What is the list of medical disorders associated with it? Why should we knowing it as clinicians? Because all of us as clinicians, we have to be familiar with such disorders so as to improve the level of care to these patients. So may I invite the first speaker, and if you have already introduced her, so let us start with that.
Thank you, Sudha ma'am. Thank you, Sudha ma'am.
Yeah, we can see your slides.
You can see the slides. Okay.
Yes.
So this talk is on psychiatric emergencies. Again, we'll go through a couple of cases.
Dr. Rona, your slides are no more to be seen.
Can you see
Earlier
them
it was there. No, no.
now? Okay. Let me just
They
Reshare.
came on for a
Reshare.
brief moment and then disappeared again.
Yeah.
one.
You can reshare.
Yeah.
Today we are moving little ahead of time. There is no problem.
Yeah. I think you will deal with postpartum psychosis also, ma'am, in your emergencies, because that is one thing we obstetrician face. Yeah.
In fact, discussing these topics was the need of the hour.
One. Okay. Can you see now?
Yes,
yeah,
yes.
yeah, ma'am. It is visible.
Okay.
Yes, yes, ma'am. We can see the next slide now.
Sorry, I'm not able to move this 1 second.
It's
Madam,
visible
you
to
please
us
right
too.
click on the screen. Ma'am, you please right click on the screen and 2 arrows will come. So by that method, you can move the slide.
No.
Right click on the main screen
Yeah.
and click the forward showing arrow.
Yeah. Can you see now? Yeah.
Yeah, it is showing
Your
definition.
second slide is visible, ma'am. Definition of psychiatric emergency.
So, emergencies, it's defined as a disturbance in thought, mood, and or action, which causes sudden distress to the individual and or to others, or a sudden disability requiring immediate management. So now this could either be a new disorder that develops in pregnancy or postpartum. It could be a chronic disorder with a relapse, or it could be an organic disorder, or it could just be an abnormal reaction to a stressful reaction. It could be iatrogenic, it could be either alcohol or drug dependence, and they could cause deliberate harm to self or others. So now, why should we know about psychiatric emergencies? Because as we've heard in previous talks, suicide is one of the leading causes of maternal death, and perinatal period is a vulnerable time for onset or recurrence of psychiatric illnesses. Perinatal suicide occurs through more violent methods compared to suicide in non-pregnant women. And again, as we've heard in talks before, women who have psychiatric emergencies who commit suicide usually have a mood disorder as well. Sorry, my slide is not moving. Okay. So now there are not very many epidemiological studies, but studies in India have shown suicidal ideation of about 7.6%. And one big risk is women with psychosis can commit infanticide. Now, a lot of symptoms of anxiety and depression are similar to pregnancy symptoms, and this is why we need to have the knowledge to identify what needs immediate intervention and what doesn't. So moving on to the case, this is Mrs. R, who's a 28-year-old primey with a BMI of 20. She had no significant medical, surgical, or family history. Now, her first trimester screening showed a PAPE of 0.3. She started on aspirin, and a growth scan at 36 weeks showed a baby with a weight of 2 kgs with Doppler changes, and she had a section for fetal distress. She was discharged on day 4. Now, Dr. Shibangi, any additional info we should have gathered? Now, this is the entire antenatal course that I've gone through in the previous slide. So anything that we have missed and anything that we should have known before? Dr. Shibangi?
Yes. So one of the important thing, Dr. Una, in this particular case is to look after is the history of IUGR or the presentation of IUGR. Apart from the
Dr.
nutritional quality,
Shubhangi, please come closer to speaker because some of the delegates are saying your voice is not audible. Yeah.
okay. So what I'm
Yeah,
talking about
better
is
now.
the presentation of IUGR. If there is a nutritional reason, one of the important reasons that can lead to IUGR is high amount of maternal stress. Okay, and that is why we need an additional information about her mental status during the pregnancy. So we can definitely look after if she's stressed out during the pregnancy by using the common questionnaires like general health questionnaire or Edinburgh questionnaire or the other questionnaires that already have been discussed about. Also, what we have to talk about is how is the psychosocial history. We have listened in the previous presentation the psychosocial risk factors. So how is her partner's support? How is her family's support? And then what is her personality like? You know, her personality being anxious or dependent or emotionally unstable. And if she has any comorbid substance use, alcohol or smoking habits. So all these things which can possibly lead to IUGR has to be asked for in this particular case.
Okay. So the postnatal course, she came back for her 2-week review. She came in with her parents. Her mother was complaining that she was trying to do everything. She was trying to look after herself. She was trying to look after the baby. She was trying to do chores around the house. And the baby at that point weighed 2.2 kgs, which was good. Baby was exclusively breastfed. On examination, the wound was healthy. But the main thing was that she also said that she had reduced sleep because she's trying to do everything herself. So we gave her advice about expressing milk, having the family look after the baby. She can express it, and the family can feed the baby and she can miss one feed. And then that way she gets at least 4 to 5 hours of sleep. So we stress the importance of getting sleep. So 4 days later, the mother called us saying that the patient has been crying all the time. She's not slept more or less a couple of days after. So not slept in 36 hours, and she was talking to herself. So the first advice we gave was just bring the mother in. Dr. Shubhangi, what are we thinking about now? So now we've got some time to organize ourselves and plan care for this lady when she comes in. So what are we going to do in that time period before she comes in?
Yeah, so what are we looking at in this particular case is she had a history of, the baby had IUGR. In the postnatal period, she's trying to do things, but she's not getting enough sleep. And then after that, what are we seeing is a sudden shift in her behavior. She's constantly crying. She's not slept for 36 hours, which is a huge duration, and she's also talking to herself. So definitely, we are looking towards sort of emergency condition and not a routine postpartum blues or depression or anxiety. We are looking towards something that is urgent, which requires urgent attention, and something that is changed in her personality pattern or her behavioral pattern. So that is why we have to, go back to our main evaluation thing that how do we assess this case? We have to go for mental status examination. So when she comes in, we have to look after how is she looking, her appearance and behavior. Okay, before we go to assess her mood or her thoughts. So in appearance and behavior, we look after her overall attire, whether she's looking enthusiastic, tired. So obviously she looked tired. She was dressed in mismatched salwar, so she's not looking, taking great care of herself. Hair are not done. She's guarded towards the clinician and aimlessly walking around the room. So what does this show? This shows that she's not trusting. She's hostile. She's maybe paranoid, and she's aimlessly walking around the room shows that her psychomotor activity is increased. She's restless and she's not settling down. She may be having a lot of thoughts. She may be having some fearfulness because of which she's, roaming around aimlessly. Then when we go ahead and talk to her, then we assess her mood, her speech, and her cognition. So when we talk to her, she may say she's depressed. Speech may be minimal. In this case, it was minimal, disjointed. And when we assess cognition, when we ask her where she is, what is happening around her, or who brought her here, she didn't seem to be oriented, impaired, short-term memory, and attention. So this shows that she was not cognitively stable at this point of time. So it's very important in any emergency condition that you take a relevant history. You take, so you can ask for what triggered it. If was there any event, was there any stressor which triggered this change in behavior? Secondly, along with this, was there any aggression? Was there any harm towards self or the baby? So this collaborative history we can have, so a background information, and when she comes, we should be doing a thorough mental status evaluation in which we first look after the appearance and behavior and get some clue whether she is, having a routine behavior or it's a changed or altered behavior, because you have seen her throughout the pregnancy and postpartum. So you can definitely make out that change. And when we talk to her, we assess her mood, speech, and her cognition.
So then the plan was for us was to call the psychiatrist immediately. So then we took, as you said, we took a history from the family to kind of ask about what brought this on, and we also did a complete examination to rule out other neurological causes. Then we organized for baseline blood investigations to rule out organic causes, so a CBC, liver function, thyroid, calcium, vitamin B12, and folate. And after talking to the psychiatrist, we said, well, the patient was going to need antipsychotics, and we had to educate the family at that point because this was something completely new. This was not something that they had known about before. So, to give medication to the mother, again, when she's breastfeeding, and then saying that this is an emergency, she needs to be admitted to a hospital under the care of a psychiatrist where there is a mother and baby unit as well.
Yes, definitely. So it's very important, Dr. Runa, that you pointed out that, in this case, the physical examination was normal. And also this organizing the blood investigation is also an important step, because we have to rule out the organic causes. In postpartum period, we have to, rule out the CVT, we have to rule out encephalitis, so any history of fever or any sepsis, a focus of sepsis has to be ruled out. And after which we have to talk to the family members and involve psychiatrists as early as possible. So here, what we are looking for is a postpartum psychosis. So it may not be, known to the family or understood by the family really very well. So meanwhile, when we ask for a psychiatric help, you can definitely settle down the patient and the relatives first.
So, psychosis in the postpartum period is defined as a condition of the mind where there is loss of touch with reality. The incidence is about 1 to 2 in 1,000. And this also increases the risk of bipolar mood disorder later on. So the presenting symptoms are usually altered thinking, where they could have delusions, altered perception, altered emotions, and in the early stages, they present with changes in mood, sleep, and concentration, and usually have unusual thoughts and vague doubts. Now, this is what we saw in this lady. There was a change in the mood, she was not sleeping, and her cognition was definitely altered. So you would see a personality change, change in functionality. She can't get through the day. She can't do her daily activities. And a thorough assessment is very important, as the diagnosis is based on the findings and there are no confirmatory tests. We have already done the investigations to rule out organic causes. And when you say psychosis, they'll definitely need to see a psychiatrist. So some of the risk factors, again, as we've mentioned before, a personal history or a family history of bipolar, history of prior psychiatric hospitalization, previous history of postpartum psychosis, if it's a long labor, a nighttime delivery, complications during delivery which were unexpected. Like in this case, she really wanted a vaginal delivery, which didn't happen, and there were concerns about the baby after as well. And though the hormonal changes are same in all women, it is the genetically vulnerable women that display, that end up with psychosis in the postpartum period. So some of the preventive measures are obtaining relevant history. Now, if you look at the risk factors, this is more or less, this would apply to most women that we see in our antenatal clinic and in labor ward. So some of the preventive measures are obtaining the history initially so that you can be prepared. You can be ready for complications later. We need to be aware about social history, and we need to educate the woman and her family, because the stigma is still there that this is a mental disorder, this might need medication, she might need admission. All of this, there is still a stigma. So educating the patient and her family is very important. And as we had mentioned before, once we do the questionnaire, we do the assessment, we can't say, well, that was fine before, so we're going to ignore it. We need to reassess at every visit. Post delivery, we need to advise them about the importance of sleep. And once she has an episode of psychosis, she started on medication, we also need to emphasize the importance of continuing with the medication.
Yes, definitely. So in this preventive measures, three things which are very important are taking the high risk history. Okay, history of psychiatric illness in the past in the patient or the family. Secondly, uh, ensuring that there is no major stress at this point of time in her perinatal period. And third is ensuring that she's getting adequate sleep postpartum, because lack of sleep is one of the important biological risk factors for development of postpartum psychosis.
So now moving on to case two, this is a 32-year-old lady who's had two normal deliveries of girl babies. She booked with us late. Now she's living in the Middle East with her husband, and she had her antenatal care till the third trimester there, and then she moved home to Chennai for her to see her mother and have the delivery at her mom's place. Now, with the history, it was uneventful, no physical illness, baby was okay. And when she came in for that first review at 28 weeks, she came with her 8-year-old daughter and her husband. So the husband was coming over to drop her off at her mother's place and then go back. So now the patient was not fluent in Tamil or English, which is the language that we speak. So then we had to speak to the husband and get a history from about her concerns. Now she had that antenatal appointment because it was 28 weeks. She had a scan and the scan showed normal growth, Leica and Doppler. And the plan was to see her back in 2 weeks. So additional info, Dr. Shubangi, anything else that we should have obtained?
Yes, in this particular case, especially when she has come from one culture to the other, whether she's really prepared for this pregnancy, because we have assumed that it's 20 weeks and she's okay with the pregnancy, whether she was ready with the pregnancy, whether she's carrying out this pregnancy in a positive way or not. How is her support system? Because husband has already left, so is she okay with the support that she already has? Having two children, what are her worries about this current pregnancy? So all these things are very important about her, environment around her during this perinatal period. Also, the mental health history. In all patients, we have to have this question in our mouth that was there any history of psychiatric illness in the past or family? Okay. If they don't know the name of the condition, if they don't come out with the condition that I had depression, anxiety, you can ask similar symptoms, that whether you had any uncontrolled worrying thoughts or any episodes where you had low mood, significant low mood, that you didn't feel like doing anything. Was there a period where you had a lot of anxiety symptoms in your body or lack of sleep? So mental health history is also very important, and the support that I talked about, because it's a major transition coming from Middle East in the mid of the pregnancy to a mother's place is one of the major transition. So a social support has to be asked for.
So then we saw her at 30 weeks. By now, the husband has now gone back to the Middle East. The patient comes with her mother, and it was very obvious that she was crying. So then the mother reported saying the patient doesn't sleep very much, eat very much, was not taking her supplements, and didn't care very much for her daughters. The patient refused an examination. We said, well, we need to lie you down, we need to listen into the baby's heartbeat, and she refused an examination. And then finally, when we convinced her to lie down on the couch, then we saw fresh self-harm marks on the abdomen and the arms, and the active bleeding from the wrist and abdomen. Then when we came out and spoke to the mother said, well, she got dressed in front of me before we came, so this is obviously either must be obviously at the hospital because they have traveled together. So this lady, when she went in to give the urine sample, this is what has happened in the restrooms. So what did we do next? We called for help, immediate first aid to treat the wounds. And we then sat her down and we said, you can tell us what is concerning you, because obviously this is a cry for help. And we assured confidentiality. And then the further history was, now the patient's husband has gone back to Dubai. And the patient is very worried that the husband will separate from her because there is a concern that she is carrying a female baby and she's already had two girls. So suicide gestures or self-harm, this is a cry for help and it needs to be taken seriously. Usually has an underlying mood disorder. It can lead to suicide if we don't act on it, and they happen impulsively in moments of crisis with a breakdown in the ability to deal with life stresses. It affects the patient, it affects the children and her entire family. So we discussed inpatient care, and again, the patient refused to go to the psychiatric unit, and she also didn't want to see anybody new. So we admitted her to the obstetric unit. We got her reviewed by the psychiatrist and the counselor, and we educated the mother as well. So, Dr. Shubhangi, what do you think are the risk factors for somebody to kind of act out like this for the first time? What would you say are the risk factors for women attempting suicide or women presenting with self harm?
Yes, so as you said rightly that suicidal attempts are always associated with a mood disorder. So the risk factors are also common in this condition. So young age women, unmarried, unplanned pregnancy or pregnancy arising out of sexual trauma, then having pregnancy related illnesses or disability. Okay, the post traumatic stress symptoms also contribute. Personal or family history of psychiatric illness or suicidal ideation. Past history of suicidal attempt is also one of the risk factors. So we cannot just neglect that, they had attempted in the past also. Because in your previous slide, you said that if it is untreated, it acts as a risk factor for the future. So these are various risk factors which can hint us towards a possible suicidal risk in a woman. And definitely we have to ask for this risk factors straight away. We cannot just not attempt asking it. Suicidal risk or suicidal ideation has to be asked with a very specific questions addressed towards the risk or the symptoms. We cannot just avoid the word suicide and go round and round and keep thinking that they might come up with the word. They don't come up usually. The suicidal risk is not talked about or they don't come out with the symptoms. We have to ask with a close-ended question only. Also, in the current pregnancy, having a partner who is not having an empathetic relationship or intimate partner violence, lack of support from a partner, or a victim of gender-based violence, then intimate partner violence, or here in this case, demand for a male child maybe is also one of the risk factors. Women who don't have a reproductive autonomy, they don't have a choice whether to get pregnant or not, or use of contraception, or no support from the partner, or maybe a family of their own, their mother, or giving birth to a female infant. So this is also, in our culture, definitely it serves as an important risk factor where they feel very helpless and they don't see any hopes ahead. So it can lead to a lot of terminal thoughts in their.
So, what are the treatment options for these ladies when you see them? Because we refer them on to you straight away. So, what are the treatment options?
So we'll talk about pharmacotherapy first, because when we are talking about psychiatric emergencies, it has to be treated aggressively and it has to be treated as early as possible. So in psychiatric emergencies, which first case that we discussed about is postpartum psychosis. The treatment of choice over there is antipsychotic. What we do is when the patient comes up with a altered behavior, a psychotic behavior, we have to calm the patient down. So first thing that we take up is verbal de-escalation. We have to talk to the patient in a very non-threatening, non-challenging way, calm the patient down. So what we can do is take the patient in a isolation, in a room, a quiet room with less people around, in a OPD full of patients or IPD with a lot of people, women around, they may get more triggered or they may get more paranoid. So moving this kind of woman to a separate room where there are very few people, maybe a trusted person from her family, and obviously you and your team, because you cannot put yourself in the risk, because such conditions are very unpredictable. A woman may get aggressive, they may get more violent. So you may have your trusted team around who are not, they are going to be supporting you in case of crisis. But there has to be a one-to-one communication with the patient, and you have to reassure the patient and make the woman trust you that you are on her side. That is one. So verbal de-escalation. Some conditions definitely they calm down because they feel that you understand them, and removing them from the triggering environment also helps. But if this doesn't help, then has to be a chemical de-escalation, which means with the help of medicine. So what we use is basically benzodiazepines. Unless the diagnosis is done as a psychosis, you can definitely use benzodiazepines like injectable lorazepam. Injectable lorazepam can be given IV or IM, which will calm the patient down, and you can definitely handle the patient more conveniently then. If the psychosis is established, then we have to use injectable antipsychotics. So we usually use first generation antipsychotics, which are very potent, very effective, and a minimum side effects. So that is something that we recommend in the emergency situations. And at the same time, you have to take the additional history, rule out the organicity, talk to the patient, derive more about their triggering events. If they're hearing any voices, if they're fearful about certain conditions, we have to talk to them, and a psychiatric referral has to be initiated. So these are the different methods by which we calm down the patient. Then other medicines that are used are mood stabilizers in case of bipolar mood disorder, antidepressants in case of suicidality, and ECTs. So ECTs, as I've already mentioned, ECTs are one of the safest treatment modality in case of postpartum psychosis and suicidal depression. So here, both the conditions, the first treatment of choice is always ECT because it shows early recovery and has less of a side effect. And but again, the consent of ECT, because in both these conditions, the patient may not have capacity to consent, because in psychosis they may have a cognitive, misjudgment, lack of insight, poor judgment. So in that case, we can take consent from the close scheme, that is a mother or the husband. And in suicidal depression, also, since they are harming themselves, we can always take a consent of their guardian. The patient may not be in a consenting capacity. Then, meanwhile, all this treatment plan has to be explained to the relatives, because they need to know that this has to be treated. Otherwise, it carries a high risk of suicide or infanticide. Okay, so there can be a irreversible complication if it is untreated, and you can understand that it is a very high energy condition. You heard in the case that she is constantly walking around. So it's a very high energy condition where the patient doesn't rest. They are constantly talking to themselves. They are not relaxing. They are not able to sleep, and they're constantly thinking about the same thing. They're very on a high alert mode. So patient needs treatment for that. It is not an option. Along with pharmacotherapy, obviously we take the patient for cognitive behavioral therapy, especially in a depression with the suicidal ideation, interpersonal therapy and family therapy, because the role of family is extremely important, because the trigger point may be in the family, there may be support system difficulties in the family, there may be interpersonal dynamics, poor dynamics with the partner or the family members. And that is why we have to take family into consideration whenever we are treating psychiatric episodes. And it is very important that the treatment is initiated in the obstetric unit. You cannot just let this patient go. This is not the condition where we treat it on a OPD basis. So it has to be initiated. A psychiatric referral has to be initiated, and then patient can be unit can be decided whether she moves to a psychiatric unit or a mother baby unit. But meanwhile, the primary treatment has to be initiated in the setup where she is seen first. Yes. Talking
How
about the preventive. Yeah.
Sorry, I was just going to ask how are we going to prevent this? What do we put in place so that it doesn't come to this?
Yes, yes, definitely. So preventive measures again work on the risk factors that we have already mentioned about. So adapting the thinking healthy manual, where we develop a positive support system for the woman in a perinatal period. Then obtaining a mental health history. So tapping that mental health high risk case by asking a single risk factor, that whether she had any psychiatric illness in the past, or a family history of a psychiatric illness in the recent or past, or maybe a current stress in her life, or financial worries, or any significant life event in her last 1 year of her life, or intimate partner violence, or any substance use. So asking for these risk factors on the time of booking is very important. Then universal screening has to be there, where we screen for suicidal ideation, or maybe in this particular case asking for suicidal risk. Okay, you may use a tool, or you can simply extend your interview from assessment of depression to asking for suicidal ideation. Then advising a patient the importance of continuation of the therapy, because as we have seen, discontinuation of the therapy treatment leads to increased risk of relapse of the condition, the underlying condition. So if the depression is relapse, the chances of suicidality also increases. Educating family and offering support that this is not a one-time treatment. It may continue for a year or so, and they have to be in a regular touch with the psychiatrist and or the mental health professional for the continuation of the treatment is very important. Constant liaising with the psychiatrist and counselor is also very important. And there has to be a team, effort between the obstetrician and the psychiatrist, and her, improvement, her emergence of the new symptoms or improvement has to be discussed. We have to take all the suicidal risks seriously. We cannot just say that she's just talking about it. She may not commit about it, but we cannot take it lightly in the perinatal period. As we have seen, suicide is the leading cause of maternal mortality overall. Okay, if we see the non-obstetric causes, suicide is one of the leading causes. And if it is a major depression with suicidal risk, if it is one of the important treatment modality, and it shows a great improvement in a short period of time. And after which, because the antidepressants, when we start, it takes time to have its proper action. All SSRIs take at least 3 to 4 weeks to have its optimum effect. So we cannot wait if the mother is suicidal and she is at the risk of having self-harm or harm to the infant. We have to start something which is very robust in the efficacy. So ECT fills in that gap. And that is why it is very important. Over to you, Dr. Ruth.
So when we are faced with a psychiatric emergency, we see that there is this woman is either kind of exhibiting symptoms of psychosis or she presents with self-harm marks. We need to look in terms of assessor. So that's the mental status examination. Listen to what she is saying and what the family members are saying as well, because when she is in a crisis mode, she is not going to be able to give you the history that you require. So, in terms of the precipitating factors and the course at home, the family would be able to tell you. So, listen to what the family members also give you in terms of history, address the current event, and in both these instances, you will have to admit the patient. Ensure safety for herself, for you, and as soon as speak to a psychiatrist. So final take home messages are, if you would look through, I mean, going through all the risk factors, it's all of the women that we see. So psychiatric history is important. Ask about mood or suicide ideas if there is any concern. Now, sometimes we do think, well, maybe she is not suicidal, maybe she doesn't have ideation. What if me asking whether you have suicidal ideation or thoughts about self-harm actually makes her do it? That is not true. We asking about it does not make the woman go ahead and either commit suicide or self-harm. So ask about mood and suicide ideas. And we definitely need to remember to check about alcohol, smoking, and substance abuse. Mood and anxiety disorders are quite common. So it's going to be about, if it's 12-13% antenatally and 20% postpartum, that's about 1 in 5 women. It can be difficult to diagnose because sometimes this presents for the first time during pregnancy. And always speak to a psychiatrist if we are in doubt.
Thank you, Dr. Runa. Thank you for that nice discussion. So I'll request now chairpersons to kindly make the comments. Yeah, Sudha ma'am.
Yes, yes. So thank you, Dr. Aruna, for putting up those real cases, beautiful real cases. And thank you, Dr. Shubhangi, for, solving them out for all of us. It was, so astonishing to, look at the data. It's a global burden. I never knew that it's the fourth leading cause of death between this prime group. And they could affect and they could inflict injuries to their infants also. So prior history, mental stress, lack of sleep, all these things are so important. And how important is the knowing the history and about the triggering factors, educating family, and keeping the stigma in mind. Also, Dr. Shwangi, you told us that how important is the support system, not only from the spouse, from the family, and from us also as treating doctors. How important is our communication system? And then, very right that timely intervention and treatment, whatever is needed, should be required at that time. So, thank you so much. The whole concept is very clear. I think the audience has taken beautiful carry home messages with them. Great.
Thank you, Dr. Sudha.
Yeah, Dr. Lakshmi needs no introduction. She is the ex-chairperson of the prestigious ICOG. And ma'am,
No,
we are waiting for your words of wisdom.
no. I must say, I mean, first and foremost, Dr. Sheila, hats off to you. You have really organized a wonderful course with RCOG on perinatal mental health issues, which is need of the hour. I have attended all the sessions from last 2 days, and Dr. Ashlesha and your team, you have done the wonderful work, and all the talks and interactions were too good. And I'm sure all our participants, they have really benefited on how to take care when we face these perinatal health issues.
Thank you so much,
Great.
ma'am.
And Dr. Sudha has summed up very well
Thank you so
about
much.
the last talk and interaction. So I don't want to repeat all the things what Sudha has already said.
Yeah. Thank you so much, Lakshmi ma'am. May I request Dr. Aruna Suman ma'am to
Yes.
make comments?
Yes, thank you for the opportunity, Sheila Mane ma'am, Pratik Tambe sir, and Dr. Anita. Thank you so much. Thank you so much, Dr. Sashi. So actually, when we face the emergency, always the psychiatrist is not ready, and we'll have to manage the cases, especially if they are aggressive. So, what is the drug exactly that we can give, Dr. Subhangi and Dr. Runa? Can you please answer us?
Yes, so the emergency drug that can be given is benzodiazepine. Injectable lorazepam that's produced. 2 milligrams you can inject intravenous or intramuscular.
And we can
Then,
wait for the psychiatrist to come the next
yes,
day.
yes. But if not next day, madam, it has to be on the
No,
same day.
then
For
only they come.
emergency?
Yes, yes.
Aruna,
It
they
is
come.
really
They
necessary.
are on call. Yeah,
Yes.
Or emergency, they do come.
No. The
Okay.
postpartum
They do come.
psychosis and suicidal ideation is, a high priority for us
Okay.
also. So it has
Yes.
to be attended as early as possible.
Okay.
Secondly, if it is not manageable with lorazepam, injectable haloperidol, that is Serenade, and
Haloperidol. Yes, we give
carbendazole
haloperidol.
25 milligrams is
Yes,
also
ma'am.
very effective.
In fact, in my hospital, most of the patients do get haloperidol when there is any
Yes,
psychological
even we
problem.
do haloperidol. We use
Yes.
haloperidol.
That
Yes.
is very safe, very effective at low dose medicine, first generation antipsychotic that we can use for acute management of violent behavior. But again, just giving this is not end of the plan. We have to hand it over to psychiatrists to diagnose this properly and start the medicine, or maybe make the plan of action for the coming few hours, because psychiatric postpartum psychosis is such an unpredictable condition. No, we cannot predict. It can change in half an hour. Also. The woman is
Okay.
crying right now. She may be violent in the next half an hour, or she may be aggressive. She may try to run away out of the ward, or she may attack some other woman. So it is very unpredictable course of action. So we cannot wait. We have to calm down the patient and make a referral as early as possible.
Okay. Thank you so much.
So, with that, we move on to our next talk. I request Dr.
Dr. Shashi, there is another interesting question. One of the delegates has asked, if the mother is breastfeeding, how can she avoid not breastfeeding in the night? I think the speaker dealt in her presentation that she can express the breast milk and refrigerate it, or maybe at room temperature, because it is taught in breastfeeding practices that in cold condition it can be kept in room temperature, at room temperature for around 3 hours, 3 hours in the fridge, and it means 3 days in the fridge, they say. So you can always express breast milk, and the family members can offer while she is trying to sleep, because if the mother is not getting adequate sleep, it will disturb her breastfeeding this thing also, practice also. So I think it is a good question. Any psychiatrist wants to make any other comment or add on to my this thing? Because it was dealt in the last presentation that how the mother can sleep while the baby is given the express breast milk by the attendants.
Yes,
So
definitely.
thank you for that question.
Very
Yeah.
important that the mother.
Shubhangi, there is one more question. If psychiatrist is not available, can we call physician as an immediate bystand? I mean, to take care of the patient.
Ma'am, ethically it is not correct.
Ethically, yeah, because now
Actually,
medico-legally,
then you have to refer the
Ma'am,
patient to a facility where the psychiatrist is available, because it has to be managed by a psychiatrist.
actually,
Sure, there
if
must
I can
be.
just Yeah, if I can just say that, anytime we have a medical emergency, where if we need a cardiologist, if we need a nephrologist, we know who to call and we know somebody on the team. We have a number, we have already spoken to them. So I think in terms of systems strengthening, we will need to have a psychiatrist on the team with whom we can just pick up the phone and say, there is an emergency, what do we do? I think the trouble is we don't have that connect. In most hospitals have a department of psychiatry. So it's just that all psychiatrists may not be that comfortable dealing with perinatal problems. But if we have a large enough volume, I think building that network is a system strengthening which we need to do. And otherwise, as Dr. as Shubhangi said, you need to do the immediate SOS, give the medication, talk to the family, shift in an ambulance to a center where she can be taken care of. I think that's something we should all.
Yes, Uma ma'am. Working
Yeah.
for the public sector hospital, not always psychiatrists are available round the clock. So we'll have to wait till the next day. So immediately
But
we'll have to treat the woman.
Yes, we have to treat over a phone call. We can get advice and make a documentation.
Yes.
So in most public hospitals, there will be an on-call psychiatrist. They may not be able to come,
In-house.
but there is an on-call psychiatrist always. Sometimes the resident may be able to come and they will consult with the consultant and give advice. But there will be someone to get phone advice for sure.
Phone
And
advice,
I feel
yes.
like after attending this talk, I would trust you guys as obstetricians to probably manage it better than a physician, if you call a
Yes.
physician. So,
Physicians, they don't take
Correct,
interest
correct.
in the perinatal health, mental health. They will not.
Yes, Lakshmi ma'am.
She's our patient, so we will take attention, we will pay her attention, and we will take her
exactly.
care. And we are in a better position because we have rapport with the patient, we have
Yes.
rapport with the family, we have rapport with the relatives, so they will listen to what we are talking. If we
Correct.
suddenly call some unknown physician, they will just, they will not listen to him.
Yeah. So,
Okay.
IT person, can you please make Dr. Sheila Mane a co-host? And with that, we move to our next talk. Please, our next topic is doctor self-care, which is a very burning topic. And there is now a lot of problems of burnout of resident doctors. So we need to discuss this. And the speakers are Asha Lasha Bagadia ma'am and Uma Ram ma'am. And I request to display the slides of both the speakers and request Lakshmi ma'am to introduce them.
They are already introduced since last 3 days. They both are
No.
conducting. Uma, hats off to
yeah.
you for all
I
the
thought
coordination
today
with RCOG. I know you have taken great initiative in coordination with the RCOG, and you have brought in topmost faculty there. Really, they all are doing wonderful job since last 3 days. So everybody are very much familiar with them.
Yeah.
In fact, I am really keen and eager to hear, because as a doctor, we never bother ourselves, we never pay attention to our own health. We also are under stress, we are also facing anxiety issues. So I'm really eager to listen to these experts how to take care of our own mental health as a doctor.
So true, Dr.
Sheila,
Lakshmi,
you wanted to say something?
self-care it's not a luxury. It's an essential part to maintain our level of performance also.
You know, ma'am, suicidal rates are increasing in doctors.
Yeah.
That is
Really?
what stressing issue now.
Particularly in residents, you see,
Yes,
no,
residents.
such a lot of stress in residents. Residents,
Yeah.
very, very disheartening to see the residents' rate of this, because these children, no, they don't know how to cope up with the stress. That is one biggest problem. Yeah.
Yeah.
So last session is the best one for us.
Yeah.
Yes.
So then I think we can proceed, so that then we can go for the.
So over to Asha Lesha Bagadia and Uma Ram ma'am.
Yeah, thank you, Dr. Sashi. So we're just going to actually, I don't think we have slides really for this. We are going to take this
We will be pleased to listen to you as such only,
conversation,
ma'am.
yeah, as a conversation. I think with all the obstetricians here and with Ashleisha having had enough interaction with all of us as obstetricians, I see ours is a field where, unlike other fields, most of the time couples and families come to us for what is a normal condition, where they don't anticipate an unhappy result or an outcome. I think that's the biggest difference between somebody, let's say in intensive care, where people are sick, much sicker all the time, and they're dealing with problems. Whereas here, we also anticipate good outcomes. Our working hours are unpredictable because, I think babies don't know whether it's Sunday or it's 2 a.m. They just show up and we have to be there. So there are a lot of these stresses. There's also, if you're in a busy unit or a busy practitioner, there's always pressure of time. There is workload. And especially as women, Ashlisha, we are constantly balancing what is professional work and our professional goals with what our need at home. And I think that's a very unique additional burden with which often there is a sense of, have I done enough? Am I guilty of letting go of one or the other? So these are, I think, unique challenges which are amplified in an obstetrician gynecologist, though it's present in any working woman's life, I'm sure. So the emotional impact of this, we don't really think about. We often just take it in our stride. We do it day after day, year after year. And then suddenly at some point, you stop and we are asking ourselves, what am I doing this for? Why you wake up in the morning and you don't seem to have the same kind of energy with which you have navigated maybe the last 4 or 5 years. So how do we recognize this emotional impact and what as the first instance? Because many of us don't even recognize that. We just think, oh, I've had an exhausting day because I've been up for 2 nights. Let me just get on with it. I think that's very often, or at best, we take a 1 day off and then we get back to work. So can you just talk a little bit about the emotional impact?
Yeah, see, this is a topic that is very close to my heart. I think, I was so excited to hear even the preamble to our talk that everyone is also, affected by this. So the impact of our work, especially your work, where you are actually in charge of two lives. And I feel that is a unique situation. No other physician has active involvement with two lives like obstetricians have, especially in the perinatal period, but even otherwise. So, the factors that affect our ability to manage this kind of stress, of course, one is our personal characteristics. You may all sort of be aware that personally you can see each of us is very different, but if our personal characteristics are where we are likely to, say, get overwhelmed by work easily, or where we prefer, it depends on which kind of characteristics can be a hampering factor. So being aware of our personal things that can actually be more vulnerable to emotional impact. So another factor could be where we prefer a lot of order and detail and planning. And does that mean that we cannot manage spontaneously? So there are different personal characteristics that lend itself to managing stress well or being succumbing to stress well. So being aware of our own characteristics, that's important. And what we also want to look for is not necessarily being at one end or the other. Like it's not like we have to be strong all the time. It's not like we have to be vulnerable all the time, but it's, can we learn from our experiences and learn to grow and accommodate around the stresses. So our personal characteristics, how we respond, how we cope with this, the stresses, and how do we balance it. That's one thing that can impact. But another thing that is a huge one for all of us, especially for obstetricians who rely a lot on multidisciplinary teams, right? You have say midwives, nurses, you have anesthetists. So you are truly working in a multidisciplinary format all the time. So your work environment can have a huge role on the impact of your work. So if you are in a workspace where you feel like you have a little bit of control, that you have a decision making capacity, you are able to decide, okay, what are my working hours going to be like, that environment will render itself to being able to manage stress better. If you have a work environment where your colleagues are supportive and understanding rather than judging and questioning and constantly sort of thinking, I'm going to do better than them. So having a supportive and receptive work and working colleagues makes a big difference. And it's interesting. Everyone thinks that having a heavy workload can be stressful, but I've seen, like you said, Dr. Uma, so many obstetricians work like crazy hours and crazy amount of workload. But if they're enjoying their work, they don't perceive it as a heavy workload. If it is not just dumped on them, then you can manage your workload, no matter how heavy it is. It's really whether you are feeling that, okay, this is too much for me. So sometimes someone may feel even a small amount of work, if they're being forced to do, it will feel like a heavy workload. So personal characteristics and work and the external environments both can have a huge impact on our emotional capacity to manage the stress.
Yes. So, so you did mention this, all these different factors which play a very important role. But when we are looking at our work schedule, sometimes it is the routine that becomes, takes over us, and we all talk about balancing work, but that achieving that balance is tricky, isn't it? Because especially when we know we want to do a lot of things, we are saying yes to many things. I think when my son was in middle school, at one point he looked at me and he said, "Amma, you can say no, you know." So, out of the mouth of babes, as they say.
Yeah.
Sometimes we do just agree to say everything. Somebody calls and says, "Can you do one article for mine?" You just say yes. And then you're sitting after them. I think a lot of people on the screen will nod because they must have been there on many occasions. So I think those kind of things, even not just to colleagues, but also to patients, sometimes we just put them ahead of everything. And if we are not there for them, we feel guilty. We feel we have failed in some manner. But I think it's fine, and that's a difference in the newer generation. Younger generation is quite clear, and sometimes we find fault with them for that as well. I have done all this, and how can you say you want off on every Saturday, for example? So I think finding that work and life balance goes a long way in addressing. But so when we are talking, it was, I think Sheila mentioned that we are seeing a lot more mental health problems. Probably the issue is resilience. So can I ask you, how do we build resilience? Because I think this is important for us to understand, because unless we build resilience, we are not going to stave off burnout, isn't it?
Yeah, absolutely.
Yeah.
So definitely, I mean, that's a very good point you made, that we are all at risk of getting burnt out. And one of the protective mechanisms for burnout is resilience. Now, before we used to think that burnout occurs in people who are, if you have been working for many, many years in a very stressful environment, then you can have burnout. But that's not necessarily true. Burnout can occur in very early stages of career as well. And the key sort of signs of burnout is feeling emotionally exhausted, like not feeling like working, not feeling like sort of having that zeal to go to work, and also being very disconnected. You're sort of looking at them as patient numbers rather than names and histories. You're distancing yourself, and no matter how much you're working, you feel like you're not achieving anything. So these kind of things, to protect it, the factors that can affect resilience, so the things that can help us improve our resilience. See, we all have coping mechanisms, and developing more positive coping mechanisms is always something that is linked to better resilience. So, and not having sort of emotional ways of coping. Oh, I'm very stressed, so I will avoid this case. I'm feeling very happy, so I will say yes to everybody. So that is more like a yo-yoing of emotional way of coping. But if you are problem based coping, prioritizing what's happening today. Do I need to cut my caseload? Do I need to give some time to my son who's complaining? So you cope with problem based coping, that is much better. And definitely what you said, taking time out. So our younger generation, as much as we might complain, I think they're forging a better way of working, right? They're sort of saying that I'm going to balance my life, so that taking time out from work, and maybe taking time out from housework as well. We often sort of end up saying, okay, we're not going to go to work, and it's at work everyone thinks we are off, but at home we are doing work again. So taking time out has to be proper taking time out, right? And giving and receiving support from colleagues is another thing that can be helpful.
Very true.
Like I said earlier, creating a positive work environment. So you may start looking around you and say, okay, how can I create one for myself? But you can also start creating a positive work environment for others, because that really builds resilience. And for many, if you look at the studies that are done in sort of disasters and stuff like that, what has actually helped is the community around them. So your team, your community, how you are able to look after each other, what you're doing today, there's so much of camaraderie that I can see amongst all of you. So that itself is building your resilience. And trying to move away from maladaptive ways of coping. And I'm sure we all have some of this. The commonest one is phone scrolling. Nowadays it has become like an easiest thing to do. So
Before you know it, 1 hour is gone or 45 minutes is
gone,
gone.
absolutely.
Gone, but you could have done productively something that is genuinely relaxing,
Yeah.
or,
Yeah, may I
I
have
think-
one question, ma'am?
Yes, Dr. Sashi.
Yeah, my own daughter is a postgraduate student in Maharashtra. So there are very long duty hours and there is a lot of burnout of resident doctors. So what is your suggestion for tackling that problem?
So, sorry, Dr. Ma, you can take this and then I'll respond.
No, I think burnout during residency, I genuinely think there has to be a lot of input into current postgraduate programs. Everywhere we hear about toxic environment, long hours, lack of
They
support.
are working
Long
19
hours,
hours continuously.
all of us have put in long hours. I don't think, 24-hour duties and 36 hours duties. I think we've all done as postgraduates. But it's also, giving them some space to understanding that every generation has a slightly different way of coping, and ensuring that they have a space to kind of come and talk to or identify that there is an issue.
Do they really get that
Institutional
space,
support.
ma'am, during duty hours?
No, so there are ways of coping with stress. I mean, certain professions do come with stress, but at the end of end of a duty, you must find some means of de-stressing. Now, this, like we do debriefing when there is an adverse event, I think having a circle of friends that you can talk to, maybe engaging, finding an activity that you enjoy, that you can just go and sing for 15 minutes. You may not be the best musician, but sometimes you find that when you sing or you just put on a Bollywood music and dance for 10 minutes, something happens in your, that just breaks you out of that oppressive feeling that is happening. So, of course, when you're a PG, you don't have control over you can't dictate your schedule, and understanding that and making provisions for it, I think is one way of dealing with it. Ashlisha,
I
any?
think,
Yeah. So,
Dr. Uma, we had an excellent discussion regarding this residents issue, particularly, because long working hours. I think collectively all of us have to come together for this,
Very
and
true.
NMC should be giving the
Yes.
guideline to all the medical colleges.
I think so, ma'am. I
So,
think
Yeah,
so one of the
NMC.
Nobody should be asked to work more than 12 hours at a time.
No, I know, but NMC
Well,
should come out with all the guidelines, and then that should be given to every medical college. As Shashi, you rightly said, most of the people from South, they go to Maharashtra, they take the seat. Within 1 month, they come back. They say, no, we cannot work like that.
so
They leave the seat.
I think
They don't
that's
mind leaving the seat, and they come back because the working pattern is really very, very stressful for them. And nowadays, the children are not like us. See, we never used to complain. We used to get adapted to whatever comes in our plate. But now the children are not like that. They want to balance the work and life. So I think the best way will be for the residents is I can say that definitely I can talk to, like, I mean, the chairperson who is there right now was our ex vice chancellor of Rajiv Gandhi University,
yeah.
Dr. Ramesh.
So can we just have
Anyway,
a few more minutes and then we'll open it
yeah.
out. So one of
Yeah,
the
in
things that
the
one more thing, I think I just want to request that still can we go on discussing because people are asking for the link because somebody's battery is low,
yeah,
somebody wants to
somebody's
see.
battery is low.
Yeah. So
in
can
the
we share the link
Sheila,
in the chat box?
just 1 minute. In the same continuity, I would like to ask Ashlesha because after the resident has committed suicide, all the friends and everyone knows why he was depressed or he was sad. So how the surrounding people like friends and family can make out, because sometimes the tiredness symptoms they mimic the depression symptom, the
yeah.
tired, loss of
So I
appetite,
was
looking sad, not taking interest. So are there any
absolutely.
clues or cues for us to pick up, I mean, for the friends and family?
So one of the things I
Okay.
was actually going to talk about while the residents
Hala, can
are
I interrupt? Can I interrupt, Ashlisha?
Yes,
Yes,
yes.
We will go ahead with discussion, but I request the backend team to share the link in the
yes,
chat
yes,
box
yes.
for the question, for the
Right,
MCQs.
right,
Yes,
right.
ma'am.
Go ahead.
Yeah.
So as much as we are saying that residents are good at taking time out, what is the one of the maladaptive coping that they do is they're spending more time interacting with each other via online meals. So there's a lot of social media presence, but there is not real connection between people. So they're not that good at sharing and talking,
True, true.
and their way of sharing is more in a through a filtered lens. They're not really having honest time, one-on-one time with each other. So encouraging them to have off-screen time with each other is one thing, because then you can pick up if there are certain changes, if someone looks a little sad. Because in the Snapchat and Instagram, you can never really know how what someone is feeling. It feels like a filtered way. So one of the things definitely is to encourage them to spend time with each other in 3D, not in 2D across a screen. And that is one thing. The other is if you notice any change in someone's behavior, which is unusual to their character. Someone who is usually gregarious and interacting has suddenly sort of become very quiet and reserved. That can give you a clue. Or if something has happened in their home and you don't really know what it is, but something has happened, then you may want to sort of keep an eye out that, okay, there's been an incident or something, some bereavement or something has happened, and maybe rally around them at that time. Of course, if anyone has a history of other ways of coping, like any addiction, alcohol, drugs, that can also, I mean, it's again, it's a very open thing now in young people. I guess in our generation, even if we did it, it was kind of hush hush, but now it's quite open. So amongst the group also, they can watch out that if someone is succumbing more to it, tending to become very upset when they're intoxicated. So those are the signs that people can watch out for, that there is a vulnerable person, and that vulnerable person is more likely to maybe do something. And again, the other thing, the flip side of that is that a lot of friends who have survived someone's suicide will be sitting and thinking, what could I have done, what could I have done? And that also can be quite troublesome for the other residents who have survived, thinking, I should have done something, I should have noticed something. The bottom line is that ultimately, even if someone is on treatment, you may look like they're doing all right. What is going on in their mind, it's very hard to know unless you are building that connection. So a debriefing of the residents after a critical incident like that is also very important to reduce their guilt. right?
So,
Great
Yes,
point.
Dr. Uma.
Yes.
no, Ashlisha, I just wanted to say that being present for our own, also for our own mental health and well-being, because the presence of the phone, the WhatsApp, the need to immediately respond, lot of activities that we do, the phone is an integral part of us. There is a lot of data today about why it is important to be mobile free or device free for certain duration of time. I mean, we are having conversations with a friend, but we are distracted because there is a message that is coming or it's pinging on your watch. I've actually given up my Apple Watch for that reason, because it just distracts you that a message is
I
coming.
didn't buy one at all. I think it's a very good idea.
So I think these are all also simple things that take away time from doing a mindfulness activity or some activity that gives you space in your head, allows you to think for yourself. What am
Yeah.
I going to prioritize today? Why do I feel bad about today, or what do I feel good about today? Um, isn't it? These are all activities that can
Absolutely.
help
And I
us
think,
cope better.
no,
These are some
absolutely.
reasons. But, ma'am, I would like to strongly say that very prolonged duty hours with deprived sleep is a very common cause of burnout of resident doctors.
That's
Absolutely.
true,
So
man.
I have some thoughts on, see, of course, I would be very grateful if all the sort of people who are at the policy level can start looking at systemically bringing about some changes. But when you are stuck in a certain kind of a role, residents usually, many people may not have a choice of what to do with their duty hours. So we know that just in terms of evidence, what are the things that you can do at work that can build your resilience and reduce the feeling of burnout. And one of the big ones that Dr. Umar said is saying no. Saying no is one thing, but what will you be left feeling is like, okay, what's going to happen? Another good thing is to learn to delegate better. I think often we might not be very good at delegating. And that can be a reason for, us feeling like, okay, we can't say no, we can't say no. So saying no goes, it's a tactic that goes very well in hand with delegating well and building a team around which you can delegate, so that person who gets delegated, their confidence comes up and then they learn how to manage and delegate further. The other thing for you people, especially when, and for all of us, I suppose, when you have day after day patients going in and out and there's so many things happening, I think you are all already very aware of, like someone said, Dr. Lakshmi said that you are know the patients well. Sometimes spending more time understanding the life stories of at least one or two patients a day, going a little bit deeper beyond their clinical case and symptoms can also add a lot of meaning to your life. You may feel like, oh, this person, I connected with her so well. So that is another thing that can add some sort of positive feeling in your work. The other thing, especially in our line of work, where we have to be diplomatic, where we have to be careful what we say. I think I supervise and sort of see a lot of doctors as patients as well. What I have found is when we have conversations that are more honest, and we've talked about breaking bad news. If you are being honest with your patients, you will also feel a lot lighter. You won't feel like, okay, you are trying to deceive them or trying to not give them bad news without giving the right information. So, learning the art of being as honest as possible will reduce your feeling of sort of burden of all the things you are taking back at home. Another common thing that Dr. Ruma pointed out, you are used to a routine on a day-to-day basis. Morning is OT, then afternoon is OPD, and then you are sort of doing cooking. So sometimes changing the routine around, maybe changing the day of when you'll be doing OPD, or just adding something new to your routine can be very refreshing. Can give you suddenly like, Monday morning I've got free time. That is amazing. So being stuck in a routine, especially if you have the luxury to do so, of course, if you don't have, that's a different thing. But changing a routine around and mixing things up can be another way of refreshing your working week. And doing this, what you are doing now, reflectively discussing with each other, spending time, and it need not be that it can be a friends group or a social thing, even within work. We know we have M&M meetings where we're discussing what went wrong, but you could also have discussions where you can discuss what went well, and how things were handled very well. So discussions on how something impacted you very well or something impacted you. So that also could be added to the discussion rather than, what could have been done better for the patients.
I think,
Uh,
Dr. Ashlesha, I one submission. And today, I like in metro cities now it is becoming a corporate world and it is becoming too competitive. And these corporate, they put so much of pressure on these people and they want youngsters because the seniors won't listen to them and they take them on full time basis and then they have the targets and then they tell them that you have to achieve this much. I think that is also giving rise to a lot of pressure on the youngsters, okay, and
Absolutely.
particularly in infertility, this IVF, I mean there is so much of pressure and the doctor, what the doctor goes through is particularly in infertility. It is not only the patient who is feeling bad, even the doctor when she has to, when she, I mean that they don't hesitate to message you at 12 a.m. that the pregnancy test is negative.
Mm,
I
that's
mean, they're
true.
under so
So,
much of stress. Yeah.
yeah.
So that even the today's practice, I think this corporate world has really made people more because then there is a competition. Nobody wants to give up the case, that if I go
Yeah.
away, somebody else will see. Then my numbers will come down. So
Mm.
these type of competitions are leading to more. I mean, adding to their stress. I feel.
Absolutely. I think you're right in terms of it's not only these public health systems where there is a lot of work, it's also the private corporate sectors. And what we have found that, so the conversations that I have with these young doctors who are stressed is that to really get them to think about what they want in their life, to give time to think, what is the kind of work you want to do, what kind of a practice do you want to build. Of course, making money is a big one on everyone's list because of the insecurity they feel, but we often get them to think. So just spending some time thinking, okay, what is my path going to be, how do I want, because many times they're just bumbling along without thinking. They're just getting through one date with the next and not even pausing to think, okay, what is it that I want. And sometimes, especially if they're in a new family, they've just got married, or talking to family members, even that is another thing that's happened where the TV is on, husband is sitting with the phone, wife is sitting with the phone, somebody's sitting with a laptop. We're not even watching things together. Everyone is watching something on their own screens. So spending time with the family, not just asking about the day, but even talking about what do you want, are you happy with this job, is this the direction you're taking. And especially when you have exams and things coming up, it's all right to sit and, like, I remember one of my consultants telling me this, that when she had exams and she had teenage boys at that time and she was giving her sort of postgraduate exams, she actually called a family meeting and said, look, for the next 2 months I'm going to be preoccupied with exams. What I would like from you is this, and what I can do is this. So I don't know how many times women do this kind of conversation. We will just go along and do what we need to do. So
Yeah.
I think asking your family what you need from them, and also offering what do you need from me, is really something that they can do to start balancing their life. Another very
So,
common thing that we have stopped doing much is having meals with someone. We are often having meals with our phone or with a device. So, having meals with someone, especially, and this is what I'm telling the young people need to do more of. It's okay if they get away, go to the sort of corner, kaka angadi or whatever we call it in Kannada. Just go to the shop, corner shop, and go and have a coffee. So be with someone when you're eating, so you're enjoying the meal, building connections, and these are the kind of things that builds a support system. If you've done that a few times, if you had a coffee with someone at your workplace, when you're struggling, you're more likely to reach out to them and say, I'm really having a tough time. If you've not done that at all, if you just said hi, hello by text messages, you're less likely to do that. So, doing this kind of, incidental socializing can be very helpful. Another thing that I think we sometimes struggle with that can affect us is when changes are occurring in our life, when changes are occurring at work, finding ways to adapt around it can be very helpful. So, teaching young people to allow change to occur, that's also useful. Some your favorite HOD may retire, and then a new person is going to come. How are you going to cope with that? You were junior, now you are in charge of the seniors. How are you going to cope with that? So adapting to change is another thing that can really help them in building a better, healthier sort of life for themselves. What do you think, Dr. Uma?
I think
Shall
absolutely
we start
there is a
discussing
lot.
after Uma's remark,
Yes.
shall we start discussing the
The answers.
answers? Yeah.
Yeah. So can I also add
We will
something?
Yes, Dr.
2
Sudha.
minutes are still there.
Yes,
So it was
Dr. Sudha, please. Yeah.
wonderful conversation, Dr. Uma, Dr. Shlesha, and a few inputs from Dr. Shashi, Dr. Lakshmi, Dr. Sheila, everyone. I think we really need to know how to incorporate. So beautifully, you have highlighted all the important things which we should be doing. We not only at junior level, at senior level also, we are also so much stressed.
Very
So
true.
few of the things which I have learned over the years with my experiences, we need to know, we need to recognize our lifelines. So we have a one tea club at our workplace wherein we all sit together, where I finish my section, I finish my hysterectomy, I finish my this thing, I come over
Excellent.
here, have a cup of tea, interact with the other person, and then we talk about our faults also. I have done wrong over this. So we are not hiding something. I think that is a big lifeline for us as a culture place. And many times we used to tell them that we are sitting so close to each other, we are discussing so much, we are not discussing that much with our family also. So that's the workplace. Number two is, when you stop comparing yourself with others, believe me, it is such a big relief. Your life journey is entirely different from the others. So, if you have to compare somebody, compare yourself with yourself only. What was when I was, maybe 2 years ago, maybe I have improved myself. I think comparison within yourself to have a better version of your is best than to compare it with the others. Then make a good support system. Believe me, if you have a good support system at home, not that only family, your helpers, I tell you, they are such a big support system in
Absolutely.
whatever you have achieved in your life. They are a big help. So try to keep them happy. Try to keep them, in a good humor. Help them so they'll become a good support system to you also. And then I just remember Indra Nooyi saying that we need to know that working women cannot have it all. So don't try to, sometimes you feel so guilty that I should have done this at that point of time. I have, somewhere neglected my children. So once I read it, in a Sunday magazine, that today's mothers, they are trying to be real. They don't try to be perfect. So don't try to become perfect. Whatever you could do at that point of time, I feel is that was the best. So stop regretting also. I should have done that time. So you did the best at that point of time, which I feel is that. So stop regretting and
Well said.
stop
Well said.
pleasing
Thank you.
everyone.
Thank you.
Stop pleasing
Stop pleasing
everyone. That's
everyone.
Thank you
what
very much.
that's for the
Absolutely.
youngsters. We have been doing
Shlesha
for
ma'am,
over the years. Yeah, at family level, at workplace. And you said, Dr. Uma, very rightly, we have to say sometimes no. And that is for, the better health. That is for our better health. So be cool sometimes and ignore everything. Thank you so much.
Such a pleasure
Thank you very
listening
much.
to you,
I
Dr.
think
Sudha.
we've had a good,
Can I ask a question, Uma
interactive
ma'am, before we
discussion.
move to? आवाज नहीं आ रही.
We'll try, Dr. Sudha, to be as cool as you are. You
No,
are really cool, calm, composed.
Dr. Lakshmi, I always used to tell my postgraduates and residents that if you, learn how to do your time management and how to prioritize your, things, you can do wonders in your life. You can
Very
do
true.
everything.
I
Can
think
I ask
Shashi can start. Shashi, can we start
Yes,
explaining the answers?
Can I ask a
Dr.
question?
Anita, Dr.
We
Anita
should
wants to
wrap
say
Can
up.
I
something.
ask a, yeah.
Yeah, Anita.
Shreya,
Yeah,
please
I
display
just
the
wanted
answers.
to ask Shlesha ma'am of Uma ma'am
care of caretakers is one important aspect which we could not discuss because of lack of time. Ma'am, just your short inputs about it, because caretakers also get depressed at times taking care of these perinatal, illnesses. So, what is your suggestion for caretakers, ma'am? Care
I
of
don't
caretakers.
know. I don't know if we can do a quick answer for that, Anita, but I think, I mean, in the interest of time, I'm not sure if we'll be able to address it fully, but it is a very important aspect of care, of caregivers of people who are constantly dealing with mental health issues. They also need the support and the downtime. And I'm sure Ashlisha has a lot of insight into that. However, I don't know if we have time to get into it now, isn't it? I'm not.
Yeah. So just as a quick thing is that
So I
um,
now
in, include husbands in your information and education from the beginning, so that if they are feeling burnout, if they are feeling anything stressed about it, then you can help pick it up early. And also, I think one of the ways to make sure the caretakers are looked after is to increase the autonomy in the patient. So often, what happens is caretakers will feel like they have to do everything. So, like I mentioned earlier, if the patient is themselves also taking good care of themselves, then the burden of the caretaker goes down.
Yeah.
So that's a short, quick answer.
True, ma'am. Thank you.
so
Thank you for that
Thank
input. Yeah.
answers
I
now.
just want to
What
give
are
a
taking?
clue. My mother-in-law was so clever. She used to keep her caretakers very happy, you know. Very
Absolutely.
happy, she used to really pamper them. Whatever she is eating, first give it to them, you know talk to them. So because they are also lonely, they have come all the way from somewhere, sometimes language problem, this that. So I
True,
really learned from her. She used to keep them very happy, you know
true,
and
true.
some
That's
gifts or
very
something.
true.
You would give them some incentives. If it is a festival day ना, buy them some bangles, some कुछ बिंदी या कुछ भी खरीदना है. Salary तो देते ही है फिर भी, because they are all young girls, so keep them happy. She is to take them out with her wherever she is going, if possible. So all those things, I think
Yeah.
we will do
Thank
one
you,
more
ma'am. Lata
session.
ma'am
We
has
will do
joined.
one more
I
session.
think we must give her opportunity to say something. Lata ma'am, welcome. You
Sorry,
want to say
I'm
something,
just,
Lata ma'am?
I'm, j-
Yeah.
I think she must be muted. Shashi, can we start
Yes,
discussing the answer?
yes. Shreya, please display the answers. I am waiting for that, ma'am. Now.
Thank you, Uma. I think really I'm feeling very happy and what I can say, really proud also that I took this initiative with you, and we did
Yeah.
this wonderful mental health.
So,
Can I
And
give you the
very
answer,
much.
Shashi?
Thank you,
so,
yeah,
Sheila, and to the ICOG for this honor, and
Anita,
to the whole
Yeah.
team of faculty who have given a lot of their time
very
over
true.
this. Thank you all very much.
Can I
madam,
read the
please
I'm
stay
answer
very
tuned
Yeah,
for
before
the
sorry
that?
Shashi.
times.
to log
Yeah,
out
Shashi,
because I
please
have a
proceed.
flight
Yeah.
to
Yeah.
catch. So
So,
I log
question.
out, and Sashi, over to you.
Yeah, thank you, Dr. Uma
Thank you.
ma'am.
Thank you.
Thanks
Thanks
a
a lot.
lot. Yeah. Bye. So the first question was, a woman with a history of bipolar disorder plans a pregnancy. She is stable on lithium. What is the most appropriate preconception advice? Our answer option is C. That means review risk versus benefits and consider special inputs before conception. Question 2, what is the best management during pregnancy? Answer is option B. Continue medication if benefits outweigh risks. Question 3, a woman with prior postpartum psychosis is pregnant now. What is the most important postnatal plan? The answer is option C, close monitoring with multidisciplinary team after delivery. Question 4, cognitive behavioral therapy CBT is particularly effective for. Answer is option A, mild to moderate anxiety and depression. Question 5, which is the gold standard for diagnosis of perinatal mental illness? Answer is option B, clinical psychiatric assessment. Question 6, which antidepressant is relatively avoided in breastfeeding? Answer is option B, fluoxetine. Question 7, Maternal untreated depression during pregnancy is associated with, answer is option B, preterm birth and low birth weight. Question 8. Which of the following medicines is commonly considered relatively safe in pregnancy for depression when indicated? Answer is SSRIs, option C. Question 9. Which of the following is considered the strongest risk factor for developing postpartum depression? Answer is option C. History of depression or anxiety in the past. Question 10. Which of the following is not a common symptom of postpartum anxiety? Answer is option D. Lack of interest in the baby. Question 11. What is a key behavioral symptom of a mother experiencing perinatal depression? Answer is option C. Difficulty bonding or interacting with the baby. Question 12. Postpartum psychosis is usually associated with increased risk of following psychiatric illness. Here, the option is B. Bipolar mood disorder. Question 13. Regarding maternal mortality, which of the following is true about perinatal suicide? Answer is option D. Suicide is a leading cause of maternal mortality in the postpartum period. Question 14. What is the approximate incidence of postpartum psychosis? Answer is option B, 1 to 2 in 1,000 births. Question 15. When screening for perinatal suicidality, what is the best approach to identify risk? Answer is D. Asking direct, specific questions about thoughts of self-harm, even if not explicitly offered by the patient. Question 16. Which medication is most associated with Epstein anomaly in the fetus? Answer is option D, lithium. Question 17. The safest immediate management of acute agitation is? Answer is B, verbal de-escalation first. In a women with, question number 18, in a women with bipolar disorder, what is the most significant risk factor for a postpartum manic episode? Here, the answer is option A, sleep deprivation during the early postpartum period. Question 19, which of the following is defined as the triad of physician's burnout according to the Maslach burnout inventory? Answer is option A, exhaustion, depersonalization, and the reduced sense of personal accomplishment. Coming to the last question, question 20, what is the primary barrier preventing many doctors from seeking mental health support? Answer is option D, stigma and fear of professional repercussions, licensing and credentialing concerns. Thank you.
Thank you, Dr. Shashi. So, with ma'am's permission, we can now propose vote of thanks. Sheila ma'am?
Yeah, please.
Yeah. Yeah.
So,
Thank you so much, ma'am.
Thank you, everyone. Yeah.
Thank you, respected dignitaries, esteemed faculty, and dear participants. As we come to the close of day 3 of this enriching academic program held on 27th, 28th, 29th, and 30th April, is my privilege to propose the vote of thanks. I begin by expressing my sincere gratitude to Dr. Bhaskar Pal, President of FOGSI, Dr. Suvarna Khadilkar, Secretary General FOGSI, Dr. Sheila Mane ma'am, Chairperson of ICOG, Dr. Sadhna Gupta, Vice Chairperson ICOG, Dr. Sarita Bhalerao ma'am, Vice President-elect ICOG, for giving us the opportunity to conduct this program, for their constant guidance and encouragement. Our heartfelt appreciation goes to our convener, Dr. Uma Ram ma'am, and co-convener, Dr. Lata Venkatraman, along with our coordinators, Dr. Anita Razoria, whose dedication ensured the smooth execution of the program. We are deeply grateful to our respected chairpersons, Dr. Surekha Tayade, Dr. Aruna Suman, Dr. Nivedita Jha, Dr. Sudha Sharma, Dr. Lakshmi Srikhande ma'am, for guiding the sessions with their expertise and insight. We missed our learned Dr. Harish Doshi and Usha Sharma ma'am. A special note of thanks to our esteemed speakers, Dr. Ashalesha Bagadia, Dr. Uma Ram, Dr. Subhangi Dare, and Dr. Ruma Benjamin for their excellent deliberations on preconception counseling of the mental disorders depression and anxiety in pregnancy, psychiatric emergencies, and doctor self-care. Your valuable insights have greatly enriched our learning experience. I would also like to acknowledge the efforts of the organizing team and the technical staff who work tirelessly behind the scenes to ensure everything runs seamlessly. Finally, I extend my sincere thanks to all the participants for your enthusiastic involvement and active participation, which truly made this program meaningful and successful. With this, we conclude day 3 of the program, and thank you all.
Thank you, Dr. Shashi and Dr. Anita, for being there for all 3 days and conducting it excellently. Okay.
And
Very
this
nice.
clap is for you, Sheila Mane madam. Wonderful,
नहीं है
wonderful. I'm in really need of the hour.
हाँ तो
Fantastic.
अभी उसका
Thank you,
they are going
everyone.
to come out
Have a
with
good time.
ICOG campus with all their
Yes.
help. Okay, so we'll come out so that we'll include all the tools and the checklist and all those things. So I'm planning to come out with that. So that gave me that idea. So thank you.
Special thanks to Uma ma'am. Special thanks to Uma
Thank
ma'am.
you.
Yeah. See,
For
Uma
guiding
had
us through.
told
Uma
me
ma'am,
beforehand only that Sheila, during your tenure, we will have one on mental health. Okay.
That's great.
Great, great. And
yeah.
Ashlesha is too good, huh?
Yeah. All of them. I
Yes,
mean,
yes,
they
yes.
are into it. They're into
The
it.
team,
Very
yeah. And your
instrumental.
team, yes.
Salisha ma'am
Wonderful work,
and
wonderful.
Vera Lakshmi ma'am,
Sitting
wonderful. All
sitting
Benjamin
here
ma'am,
3 days, 3 hours each day, 9 hours is not a joke. But
yeah.
the Ashlesha ka team and Umaram, they have really done a wonderful work.
From Australia, ma'am. Ashlesha madam
Yeah,
has joined us. Yeah, that's great.
that
Thanks
is
to
what I am
her.
appreciating. I could make out that they are from outside India. That is what I'm saying. 3 hours per day for 3 days. I mean, real
And
commitment.
first day, whole day, we had Dr. Prabha, which is the director of NIMANS. Okay.
Oh, yes.
She's the director. Very, I mean, a very high post, big post. We know her very well because we have invited her on many occasions in BSOG. So she is
That is
like a
what
friend
is
to us. And
real
we
commitment.
also created a helpline for the nursing homes for these problems.